Welcome to the Symposium on Advanced Wound Care and Wound Healing Society virtual pre-conference, Pressure Injury Detection, Prevention, and Treatment, a Virtual Experience. This workshop is supported by educational grants from Abbott, Convatec, Dermatherapy by Standard Textile, EHOB, Hillrom, Medela, Menlica Healthcare, and Smith & Nephew. Immerse yourself in this dynamic and expansive virtual experience featuring key updates and the evidence related to technology for the detection, prevention, and treatment of pressure injuries, led by the National Pressure Injury Advisory Panel, followed by a separate but complementary workshop led by industry partners and key opinion leaders. Our presenters will answer questions at the end of the workshop. In the meantime, we invite you to explore each presenter's profile for slide downloads and other resources. We encourage you to chat with our presenters and your colleagues throughout the session. Thank you, and enjoy the virtual workshop.
Hello, everyone. I'm Janet Cuddigan, the president of the National Pressure Injury Advisory Panel, and I want to thank the sponsors of SAWC for inviting me and the Vice President of NPIAP, Dr. Joyce Pittman, to present today on pressure injury detection, prevention, and treatment, a virtual experience. Our focus today will be on what is new in the 2019 International Guideline, which we developed with the EPUAP and NPIAP. I've listed the two faculty members and our respective affiliations. Neither Dr. Pittman nor I have any financial relationships to disclose relating to the subject matter of this presentation. The objectives today are to describe key updates in the evidence relating to technology for detection, prevention, and treatment of pressure injuries. So the key is looking at the guideline and asking, can technology help implement the guideline? Here's a picture of the guideline. You can order the guideline from the website listed below. I would recommend, if you're new to the international guideline, that you first look at the quick reference guide. It will contain all of the recommendations and good practice statements and give you a very nice overview of the results of our 2-year effort in producing this guideline. For a little bit more detail, you may want to look at the clinical practice guideline, and what that document adds is a summary of all the research that went into constructing the evidence-based guidelines. There are also some very useful tips regarding how to implement the guideline. So I'd invite you to start with the quick reference guide and then move on to the full clinical practice guideline. This is a third in a series of international guidelines that we've done with the EPUAP and PPPIA. Much of the structure has been the same for years. It's worked rather well. The 3 organizations formed a guideline governance group and worked with a methodologist, Dr. Emily Haesler, in Australia. What is new this time is that we added 14 associate organizations, people who focus on wound care throughout the world, and I think we've covered most of the world with that. One of these organizations that you may be familiar with is the WCET, which is really a global organization. The other thing that's new is that we did a survey of over 1,000 patient consumers. We'll tell you a little bit more detail about that. That was instrumental in guiding the questions we asked and trying to match what were concerns for consumers to the evidence and the guidelines. As in prior years, we had registered stakeholders, including people from industry, and we had 28 small working groups with 183 members throughout the world. This is a picture of the guideline governance group. These are the 12 people who met every month, I call them my 5 a.m. Zoom buddies because it was 5 a.m. in Omaha and Lord knows what time around the world. Grew very close to these people and learned a lot about them, about how people are preventing and treating pressure injuries in other countries. This presentation is really a segue or a bridge between the research and the guideline and the role of industry. There are very strict rules about guideline development, so we did not have any industry funding or influence during the guideline development process. The organizations covered all the costs. We had very strict conflict of interest vetting of guideline governance group members, and people truly did, like at an NIH study section, walk out if they had a conflict and they were absolutely no part of the discussion. The small working group members were vetted by conflict of interest by topic. So perhaps you would work for a company that produced dressings, but you were certainly free to exercise and share your expertise on another topic, perhaps treatment. Stakeholder reviews is the first place we really actively involved the industry stakeholders. We put out the initial draft of the recommendations, and we asked individual clinicians, professional organizations, and industry stakeholders to comment on them. We specifically asked, did we miss any evidence? And we looked at many articles that people submitted, and we reviewed all comments that were submitted in detail and changed the guideline based on that. The dissemination phase is really where industry has a major role. Industry sponsors really came forward for us for both the launch event and for also sponsoring guideline dissemination. We have been very gratified at NPIAP by the number of our CAC members who have produced education materials in relation to the guideline, facilitated implementation, and had great suggestions and even funded some projects for the ongoing research that is needed for a better research base. These are the sponsors from the launch event, which was held in November at USC. And these are the sponsors for guideline dissemination. And again, our thanks and appreciation to all of these companies. So what's new in the guideline methodology? Well, there's a 40-page document on methodology, and I'm not going to bore you with it, but I do want to highlight a couple new aspects. And those are the consumer involvement and the new formatting that's involved. The consumer guideline surveyed over 1,000 people throughout the world. And we basically asked, what's important to you? What do we need to know as guideline developers to really meet your needs? I'll give you a little hint of this. We're preparing a manuscript for publication, but the number one concern was management of pain for people who had pressure injuries. And what was really palpable in people who are at high risk for pressure injuries, elderly individuals, people with spinal cord injury, was the continuous fear that they were going to develop a pressure injury and it was going to radically change their life. And they were hungry for any information, any products, any way to prevent that pressure injury from happening. The stakeholder reviews, we had over 1,200 people invited and 699 responded. I'm frequently asked, you know, I really have this great study on pressure injury prevention or treatment, but I don't see it in the guideline. What's the story? Well, let me tell you a little bit about how we looked at the evidence. We had extensive database searches, and the search terms were worked out with some of our best librarians. But even the best search only comes up with about 90% of what's relevant. So we really depended on people, especially in the stakeholder session, of giving us some more insights on articles. We also had inclusion dates, and if it was published after August 31st, it didn't make it into the guideline, but we've continuously updated the resources in preparation for our 2024 guideline. It also had to be in a peer-reviewed journal, minimum of 10 subjects, and there were some quality appraisal standards that needed to be met. The small working groups worked very hard looking at all that evidence, checking for eligibility criteria, extracting data into the tables, analyzing the data, assigning levels of evidence, summarizing the evidence, and then saying, hey, do we have enough to really make a recommendation for practice, and drafting recommendations based on that. This is something I'm sure you're very familiar with, the levels of evidence with the randomized controls being at the top. We paid attention to that because there's less bias in a randomized control trial than some of the other studies. The strength of evidence rating for the recommendation is sort of a cumulative view. Do I have enough information to really make a recommendation, and at what level? And it combined the idea of what kind of studies, how many studies, were they consistent, and did they meet quality appraisals? The only thing I want to emphasize on this is when you look at the guideline, C is not expert opinion. There is some evidence around that. So the research was rigorously analyzed, but how do I make it work in the real world? Which leads us to the whole area of translational research. I like to think of guidelines as a bridge between research and practice. And in the research world, we're really asking, does the intervention work in humans? Is it efficacious? That process favors internal validity, and it's a very tightly controlled design that there's no way you could do it exactly that way in clinical practice. Now, in practice, we're asking, does the intervention work in the real world? Is it effective with patients? If it's two interventions, we look at comparative effectiveness, and it favors external validity. Can we generalize it, but not at the expense of the core? And we're very realistic that it's tightly controlled with research, but we have to adapt the intervention to the environment, to the clinical setting when we implement it. The whole focus of this presentation is, can technology be part of that bridge between research and practice? And I think by the end, you're going to say the answer is a resounding yes. So strength of recommendation is another way that we tried to get at, is this something you really want to look at? And basically, we asked some of our developers, would this recommendation be something that you use with the patients you are concerned about? Would it do more good than harm? And we had several ratings, and in general, everybody said, yes, do it. Strong recommendation, probably do it. And there are some that, yeah, it's a new area of research, but I'm not sure that I'd try it. And maybe that needs a little marketing and convincing. So here's the new guideline format. I'm going to sort of orient you to this. I'm just looking at the green sections, the clinical questions, etc., with an example from the medical device section. We always start with a clinical question, like what factors should be considered when you select and fit a medical device? A lot of good research on what are the right materials and the right fit. What local management strategies are effective in preventing medical device-related pressure injury? And is a prophylactic dressing effective? And if so, which one should I pick? Good practice statements are statements that nobody's ever really done a research study on, but it's something that is just good common sense. So it's good common sense to assess the skin under and around the medical devices for injury. It's good common sense to reduce and redistribute the pressure by rotating, repositioning, physically supporting, and removing the device as soon as possible. So that's an example of good practice statements. Now, when we had evidence, we made an evidence-based recommendation, and we do have very strong evidence to use a prophylactic dressing under a medical device. And also there's some good studies that say if you rotate out a mask versus prongs in neonates, just a different area of pressure, you have fewer facial injuries. Implementation considerations are a new feature of this guideline. It's trying to bridge that gap between the research, the recommendation, and how you'd actually implement it. And it's guidance like, don't layer up the prophylactic dressings. You're just going to increase the pressure. Ensure the functionality of the medical device isn't compromised by the dressing. Consider the following factors: ability of the prophylactic dressing to manage moisture and microclimate, especially when used with a medical device that may be in contact with body fluids, ease of application, and ability to assess the skin regularly. So those are the implementation. So I'm done with methodology and kind of the overview of the guideline. Let's dig into what's really new in prevention based on this guideline. One of the chapters we were very, very excited about was the etiology of pressure injuries chapter. Dr. Amit Geffen, our panel member Dave Brienza, our former president of NPIAP, Laura Edsberg worked really hard on this chapter, looking at all the basic science, the biomedical engineering that goes into our understanding of what causes pressure injuries. I think you're all used to the ischemic model or the classic model. This is what I grew up with, and it basically says you put enough pressure on to compress the capillaries, you're not going to get blood flow and the tissue's going to die. You're going to get ischemia, injury, inflammation, and infarct. And kind of, think about those 4 I's because they're a story throughout. Now, there's evidence to document that this does happen, this capillary closure. But what we found in the 2000s, some of the work with Amit Geffen, was a newer model that says, hey, tissues and cells are deformed much earlier and at lower pressures than the effects you see from the capillary closure. It affects different tissues differently, and it still has the same effects, the ischemia, injury, inflammation, and infarct. Pretty scary to think that it happens earlier and at lower pressure. And then there's a whole body of evidence that says reperfusion injury is a factor that supports, in a negative sense, supports the injury that we see from the other 2 etiologies. This is a blow-up of a diagram that Dr. Amit Geffen put in the guideline, and it deals with that newer model that basically the pressure, even if it's fairly low, can deform cells. The cells die. You get inflammation. You get edema, increased interstitial pressure. Cells distort more. The plasma membrane creates pores. You lose cytoskeletal integrity, and you have sustained tissue deformation. And it's a cyclical process of worsening. So it isn't just cutting off capillaries. It's a bigger story than that. So think about that. Think about what we know about etiology as we go through prevention. These are the broad areas of prevention. They're basically unchanged, but we're going to find some new evidence and new nuances. Let's start with risk factors. None of this is going to surprise you. Risk assessment on admission, routinely with changed structured approach, comprehensive skin assessment, risk tools with additional factors, always use clinical judgment, and then whatever you find on the risk assessment is your basis for risk-based planning. We did a total new analysis of the epidemiological evidence on risk factors for pressure injuries, and the strongest factors, no big surprise here, limited mobility, limited activity, and a high potential for friction and shear. Those are sort of the sine qua non. You're not going to get a pressure injury from moisture if you aren't also not moving or have limited activity. We also sort of graded some of the other risk factors, and you can see the levels, the A, B, 1, C, and good practice statements on some of the other risk factors that we're very familiar with, like perfusion and circulation deficits. We also looked at it by setting, and this is a brief summary of the additional risk factors in perioperative critical care, neonates and children, and some other additional risk factors in neonates and children. In these special populations, look at these in addition to Braden scale or whatever scale you use. So here's sort of the new twist on risk assessment. We're encouraging people, don't worry about do you have your Braden scale down in 8 or 12 hours. Look at that patient when they come in. Are they not moving? Are they at high risk? Start instituting some prevention early. Do a full risk assessment within that 8 hours, and always use the risk, modifiable risk, as a basis for planning. So risk assessment, you're going to see several of these slides. We went as far as we could in terms of taking the research into practice. But there are some implementation challenges. For example, how do you do effective screening in a very busy clinical situation like an ED? There's so many risk factors and so little time to assess them. So can technology help? Not ready for prime time yet, guys, but I think that there is a lot of research being done in machine learning and artificial intelligence that allow you to look at the risk factors in the EHR and come up with a risk score so you can zero in on those high-risk people for multiple risk factors. But we still need to identify and mitigate the modifiable risk factors. So that's risk assessment. Next is tissue assessment, and Dr. Pittman will also talk about this to a certain degree. I'm talking about this in terms of when you're doing your standard skin assessments, how do you pick up any sign of injury early? And to sort of give a short summary of this, temperature, especially thermography, infrared thermography, is very helpful. Subepidermal moisture has enough evidence for a recommendation. And this is especially important to use in darkly pigmented skin, and a color chart may help. Now, there are a whole series of technologies we looked at. Some are very promising, but they don't have the research at this point in time to really recommend them. So let's talk about the two that have research. Subepidermal moisture. Basically what this is looking at is that whole process that Meet Geffen talked about, the moisture and the edema, the microedema. You can pick it up on a subepidermal moisture measurement sensor much earlier. It started with the basic work that Bates-Jensen did. I like the O'Brien study in that he found that you can pick it up several days, the damage several days, the beginning edema several days before the nurse can visually assess any damage. And they tried it and said, hey, does it make any difference in HAPIs? And the Raisman study shows that. The other sort of strong technology in skin assessment is thermal imaging. And again, Dr. Pittman's going to talk about this in relation to looking at wounds. But I want to talk specifically about the situations where a person comes in, look at the figure on the left. I look at that. I don't see any problem. That looks totally normal to me. I wouldn't pick up a pressure injury. But look at the thermography scan. Look at the deep purple targeted bullseye. This is a deep tissue injury that just hasn't manifested itself so we could see it on the skin. So for normal tissue, what we're finding is if there's inflammation starting in that process, it'll be warmer, and if the tissue has died, it'll be cold and infarcted. Here's some of the key studies we looked at for the guideline on thermography. And also there's a more recent study by Corner that talks about how you can use thermography on admission screenings. So skin and tissue assessment. Implementation challenges. We know that damage occurs long before we can detect it on clinical exam. And assessments are particularly difficult in darkly pigmented skin. So we know from the evidence that thermography, subepidermal moisture can help with that, and additional technologies are being tested. Next, the area of preventative skincare. None of this is going to surprise you. Implement a skincare regime, keep the skin clean and dry, clean promptly after episodes of incontinence, use alkaline soaps and cleansers, barrier products, don't vigorously rub the skin. And I think some of our industry colleagues are going to have a lot more to say on what are the appropriate technologies and products to really fulfill these. We also found evidence, and it's increased evidence if it's in red, B1, increased evidence, that high absorbency incontinence products work. We know from the last guideline and the evidence stays strong that textiles with low friction coefficients are very helpful, and soft silicone multi-layer foam dressings are also very helpful for prevention. So preventative skincare. Here's the implementation challenges. Do barrier products really work? Well, we found evidence to say yes. How can we protect against friction and shear? If you haven't tried the textiles with low friction coefficient, there is solid evidence on that. How can we protect against pressure and shear? Very, very solid evidence on soft silicone multi-layer foam dressings or prophylactic dressings. That final challenge, cleanse properly after incontinence. How do we know when to cleanse? Especially in a patient who is cognitively impaired, they may not tell you, and it may be hours before you round again and find it. Hold that thought, because there's going to be a presentation on how do we know when to cleanse. Repositioning early mobilization. We want to reposition all individuals with or at risk of pressure injuries on an individualized schedule. That's as much and as best we could say with the research that we had. The problem is it's messy clinically, isn't it, to try to discern when you should turn a patient. We say consider their level of activity, mobility, ability to independently reposition. You can look at a Braden subscale for activity mobility, but if it was done at 8 a.m., they went to surgery, suddenly their mobility and activity are different. So we need better ways to know when is the patient turning and when do we need to assist. And there are also some guidance. There's some guidance for repositioning frequency and keeping the head of the bed as flat as possible. Here's what we came up with in the evidence, and I think that these are technologies that you're going to see a lot more of. We broadly categorize this as repositioning reminder strategies. Very strong evidence on wearable sternal sensors that will sense if the patient is moved, how often, how completely, and give the nurse feedback that says that patient hasn't turned very much or not enough or enough to offload in the past 2 hours. I need to get in there and do it. And I don't need to wake them up every 2 hours in the middle of the night just to meet my turn-in schedule. We want to reduce friction and shear, and the handling equipment that we use to that is vital. And also continuous bedside pressure mapping. Continuous bedside pressure mapping is another very important tool with good evidence. Remember, C means there's evidence, but there were some inconsistencies in the studies on this one. So implementation challenges about repositioning and early mobilization. Really tough to reposition, 40 people in your ward on an individualized schedule. How do you assess how the patient's moving themselves and when we need to step in? How do you know if you've effectively redistributed the pressure? And what positioning devices are best? So look at the technologies. The wearable sternal sensors, there's wonderful evidence on. Continuous bedside pressure mapping to guide repositioning. There's some great examples of this on some recent position guides that the NPIP just put out on our website. You can actually see here's a red spot under the sacrum. If I adjust slightly, I can get rid of it. And that's what we mean by guiding repositioning. And I don't have evidence on this, but really, we got to start thinking beyond pillows for repositioning. What are the best repositioning devices? I'm not going to go through the details on this, but we want to promote seating, pressure relieving maneuvers, early mobilization programs. One of the new things in the guideline is that we develop diagrams on common positioning in the OR. I think as many of us go back into the ORs as OR elective procedures have been stalled out, these are good reminders. And we're getting people who have postponed their surgery, and now they're much sicker and much more prone to pressure injuries. What surfaces, what positioning devices, in addition to really knowing the positions of the OR, are going to help us. Heel pressure injuries, you can look at a leg, and if it doesn't have hair and you can't feel a pulse and the toenails are thickened, you think, hey, the perfusion's not very good. But think of the technologies like transcutaneous O2, CO2, ABIs, Dopplers, and there's some newer products that are coming out that really look at the oxygen in the tissue without all the hassle of a true transcutaneous O2. Offload the heel completely. How are we doing that? Pillows work sometimes, but not very well. What devices work best? And of course, the prophylactic dressings as an adjunct. Support surfaces. Nothing's going to surprise you here about how to select a support surface, but it's not as difficult and easy in practice as it seems with these guidelines. We do have evidence on high specification reactive single level foam mattresses, allowing you to lengthen your time in between turnings. But nobody really knows what a high specification foam is, and our S3I group at NPI is investigating this further. There's also evidence for many of the options that I have highlighted in green here. But here's the implementation challenges. We know we can safely extend the time between repositioning with a, quote, better support surface. But what are those surfaces? They're randomized controlled trials on support surfaces, but they're extremely expensive to conduct, very high numbers, and we don't always have the clear evidence for implementation. There are so many integrated support surfaces. There may be a 10-year-old study on air fluidized beds, but the newer integrated support surface may have a section that's air fluidized, a section that's alternating pressure. It may have sensors built in that adapt to the patient, and we really haven't tested those multiple features. So how do we know what to purchase? I had surgery last January and had an overnight stay, and I turned over and I noticed the bed was doing something. What was it doing? I finally realized there were embedded sensors that were adjusting to me as I repositioned. We haven't tested that in an RCT. What I can offer is the NPIAP has a support surface initiative with definitions, standards, and workshops on how to take the technology and the technological standards and make better decisions about what beds you buy. Finally, what's new in nutrition? I have one slide on that, and it's sort of an overview of a very rich, very deep chapter. Big emphasis on screening and assessment of nutritional status. There are better tools than the Braden subscale score, and a lot of detail in the chapter on that. As far as prevention, they don't focus on a number of calories or how much protein, but they do say you want to individualize protein intake to maximize it. Not necessarily be prescriptive. Now, it becomes prescriptive when you get to the treatment side, and I'll let you look at the guideline on the exact measures, the 30 to 35 kilocalories per kilogram per body weight, et cetera, and the protein grams per kilogram. What's new, I think, in the guideline is consider high energy, high protein supplements containing arginine, zinc, and antioxidants. Now, this is all pretty vague, especially to a nurse. Maybe a dietitian could pick this up and run with it. That's why we need the partnership with our collaborators. You will hear from a manufacturer of some wonderful nutritional products this afternoon. This company has also worked hand in hand very closely with the NPIAP to produce informatics that are available on the NPIAP website that helps you walk the research across the bridge into implementation. So I'm going to briefly summarize. Our whole goal of writing this guideline was implementation into practice. And I have a few questions that you can ask yourself as you're looking at your protocols, like, are we doing screening? Are we doing a full risk assessment? Are we planning and implementing based on risk? Are we really doing comprehensive skin assessments and using those new technologies? Do we have appropriate skincare products and procedures? Are we using the best support surfaces? With repositioning frequency, do we really have the technology that's going to assist us? And medical devices, do we really have the technology that will prevent those and the protocols for that? These are just a few of the questions as you go to implement what we put in the guideline. But I think the biggest question for today is, can technology help? And I pointed out several places in the area of prevention where technology is vital. It's going to carry us over to an effective implementation. And I know sort of the pushback, we can't buy another product, but I think there's also some very good cost effectiveness studies that in the long run, you're not only providing the best quality for your patient, but doing it in a cost effective way if you consider some of these new technologies. And with that, I will say thank you for your time and attention, and I will turn the podium or the Zoom square over to my colleague, Dr. Joyce Pittman, who will be talking about technology help detection and treatment. Thank you.
Hello. Thank you, Dr. Cuddigan, for that wonderful session and for the prelude to treatment and talking about technology as we look at detection and treatment and the guidelines and what do they say about it. So let's talk about it. So some of this is going to repeat some of what Dr. Cuddigan talked about, but technology can be very instrumental as we're doing that comprehensive initial assessment. And that is a guide to how we're going to treat, right? So it's not only a guide to prevention, but it's a guide to the actual detection of a pressure injury. Is it a pressure injury? And then treatment. We need to set treatment goals that are consistent with the value and goals of the individual. Dr. Cuddigan already talked about that. Some of the guidelines really stress that, consistent with the individual, looking at that individual's needs, and then monitoring the progress. Remember, the basics of treatment is always cleansing, debridement, pain management, assessment, management of infection and biofilms, and the wound dressings. So consider the biological dressings, growth factors, biophysical agents, and surgery. So let's go into detail. Again, a reminder, because if you don't have the basics, you don't want to just treat. We've got a lot of advanced technologies and treatments, and you don't slap a dressing on a wound. You need to look at the etiology. What do I need to be addressing? And as Dr. Cuddigan eloquently explained, and with the graphics and in the guideline, the primary cause of a pressure injury is the sustained mechanical load that's applied, usually over bony prominence, but it causes that focal deformation of the skin and or deeper tissues. So the damage is determined by the duration of time of the mechanical load and the biomechanical tolerance of the tissue. And that's the clinical picture. Within minutes, and that's what is significantly different, I think, in the guideline, that etiology chapter really shows us that tissue deformation starts within minutes, and it can cause damage to the cells, which leads to that inflammatory edema, increased interstitial pressure, ischemia, and cell death. So what does the evidence say? It tells us, and the guideline is a great resource for you that looks at the evidence. Remember the methodology that Dr. Cuddigan shared, the extensive lit review, the extensive appraisal process. So it tells us to conduct a comprehensive skin and tissue assessment for all individuals at risk for pressure injuries. That assessment should include erythema, blanchable or non, temperature differences, tissue consistency differences, and pain at pressure points. And then the assessment of darkly pigmented skin is really key, and we need to pay attention to that. So what does the evidence say? It tells us, and the guideline offers the evidence, as Dr. Cuddigan eloquently stated, thermography. There's a well-supported, and the evidence is there for thermography, and then also for the subepidermal moisture and edema measurement devices. And this assists us, it augments our physical, visual assessment. We have technology that assesses the temperature of the skin, the subepidermal moisture and edema. I want to focus on the darkly pigmented skin. We've already talked about thermography and the subepidermal moisture. I want to talk about darkly pigmented skin. Those two technologies, especially as we're thinking of detection and treatment, determining if this is a pressure injury or if it's something else. Assessing the temperature of the skin and soft tissue can be an important adjunct assessment, and there is evidence to support that. Even so, it is difficult sometimes with some of the darker skin tones to compare. So always make sure, just common sense again, don't forget the common sense stuff. If we're concerned about a heel on someone with darkly pigmented skin, how about looking at the other heel? Do a comparison on the same skin tones. But you could use a color chart to assess that determination of differences in skin tones and skin color. Pressure injuries are often undetected in our individuals with darker skin tones, and where the skin abnormalities may be more difficult to visually detect. I gave you some additional resources here because it's so, I'm doing some other work, and it is critical that we assess all individuals and taking into account those with darker skin tones. So we need to really pay attention to this. And again, use your technology that you're going to learn about in the virtual experience to help you think about that if your population is a high population of a variety of skin tones. We also want to look and differentiate pressure injuries from other types of wounds. And this is a good practice statement in the guideline. And what do I mean by this? I mean, you guys in the clinical setting, you know this. I mean, how many times do some of your staff have problems differentiating a stage 2 pressure injury from moisture associated? Well, some of our technology can do that in looking at whether it's a hot or a cold lesion. The other thing you want to think about when you're looking at detection is you want to use a pressure injury classification system to classify and document the level of the tissue loss. Now, this is a good practice statement. I think mostly in the U.S., we're pretty standard at using the NPIAP standard definitions. In the international community, there are some other classification systems, but whatever you use, the thought here is to do it consistently and to have a structured approach. And then 10.4 recommendation talks about assessing the pressure injury initially and reassessing at least weekly. And this is a good practice statement. This is when the evidence was not as strong for as we were providing a level of evidence, so it's a good practice statement. We had as Dr. Cadogan mentioned, we have a little struggle with setting time frames because everyone's different, every individual is different, the setting is different, the frequency of even seeing the patient is different. But initially, when you're looking at wound and the pressure injury characteristics, in order to monitor progress, you really need to be looking at it weekly to see if you're going the right direction. I've got lots of grandkids, so of course I'm looking at building blocks and I'm looking at layers and Legos, and each one builds on the other. And think of a systematic approach to whatever method you're doing for assessment. You want to select a uniform, consistent method for measuring pressure injury size and surface area to facilitate those meaningful comparisons of wound measurement. Currently I'm in the academic setting, but I've been a clinician all of my life. And I've been in large systems with extensive and well-known electronic health records. Even so, there are limitations in looking at your wound outcomes. In your documentation, in your system, do you know if your wounds are doing better or worse, or do you have to go in manually to look at the actual measurements? Or is it able to produce some reports for you so you can trend outcomes? So I think this is something for you to really think about. We have such advances in technology that we have to integrate them. We have to figure out a way to integrate them into our current practice. There are many wound assessment analytic software platforms. Unfortunately, some of the major EHR systems don't have these platforms. Now, many of them integrate into these common EHR systems, but our platforms don't talk to each other. Don't get me going on this. It is frustrating, and I know you are probably as frustrated as I, but there is technology out there, and we have to stand and almost require it. So we need a uniform, consistent method for wound assessment and measurement. So do we need to have an analytic software platform that would integrate into our EHRs? What about photography? Many of us do it. Some places say don't do it. Some places do it. But whatever, you need to have a process. Do you see the guideline says a validated tool to monitor pressure injury healing. Determine what your structure is. What is your process? And have a process surrounding your photography, whether you do it weekly, whatever. And then there is evidence in the guidelines surrounding thermography, and there is some evidence about using ultrasound. So check out those chapters and those recommendations. I put this tool or this table in the presentation because I just thought it was a nice table that looks at some of the assessment and monitoring tools that there is evidence on. The Design R, the BWAT, the PUSH tool, and the spinal cord impairment pressure ulcer monitoring tool. These all have been psychometrically tested, and that information is out there. My question to you as we think about implementation, is this integrated into your EHR, into your assessment? If you're not using one of these tools, what are you using? Do you have a template? A structured, consistent method to monitor progress is what's needed. So now let's talk about treatment. How do we use technology to augment our treatment? But I want you to remember, in addition to treatment, you always have to have those prevention strategies in place because they minimize progression or worsening of a pressure injury, and they are key components as to our ongoing treatment. Don't forget your turning in positioning. What is your process? Assistive equipment. What do you have in place? Do you have a process surrounding it, or is it hit and miss? Does it depend if you have time to go get it? What reminder systems do you have in place, whether they're manual, something you stick on the end of the bed, or is it an alert that's in your EHR, or is it some of our turning and positioning alert systems that our industry partners are going to be presenting to you? There is technology out there to help us do our work better. Textiles that address those key risk factors. Equipment focused to specific anatomical locations to help offload and minimize pressure. The pressure mapping devices. Prophylactic dressings on those high-risk anatomical locations during the periods when there's increased pressure. Do you have a process surrounding those? And then EHR enhancements related to nutrition, positioning, risk, etc. Some of our predictive modeling techniques. So again, there's technology. Be on the alert to look for it. There's new research and there's new things coming out every day. Other technology to augment treatment. Some of these, as Dr. Cuddigan mentioned, are not new in the guideline, but again, there is new technology every day. So some of our non-pharmacologic pain management strategies to reduce the pain, we need to be thinking of those as a first-line strategy and as adjuvant therapy. Music therapy, do you have that available to your patients? Your electrotherapy, your virtual reality, and that is really cool. And then I want you to think about cleansing the pressure injury. What technology do we have to use? There's pulse lavage, and there's evidence in the guideline that supports this. More technology to augment treatment. Thinking about those basics of treatment, and of course debridement is one of the basics that has to be incorporated into your practice. Debridement either of the devitalized tissue or of the suspected or confirmed biofilm, and to perform maintenance debridement of that wound. So low frequency ultrasound, contact and non-contact. Here's some studies that support that. The hydrosurgical water knife. The guideline provides you some evidence to support these technologies. Another thing to think about with treatment is some of those other dressings. There is a recommendation with good evidence to support collagen dressings for those non-healing pressure injuries to improve the rate of healing and decrease signs of wound and inflammation. There was not enough evidence for specific recommendations on some of these other topical things, hyaluronic acid, derivative wound dressings, bilayered cell therapy, amniotic. Remember, this guideline, we could only use the evidence that was available at the time of our dates. So new evidence is coming out daily. So just be aware, looking for the evidence to support your practice. And we can't forget negative pressure wound therapy. It has become almost a mainstay of many of our treatment modalities. So this recommendation has not changed, but you really need to be thinking about negative pressure wound therapy as an early adjunct therapy for reducing the size and the depth of pressure injuries. But think about, too, go beyond that. Negative pressure, what else is being added? New technologies are being added to this modality frequently. So we now have installation, we have disposable units. There are different aspects of different brands so that you can use whatever is helpful, and as you individualize the care to your patient and to their resources. So really think about technology and be aware of the new aspects of the treatments as they become available. Again, think about growth factors. Think about biophysical agents. Think about how can we deliver oxygen via the positive pressure, electromagnetic, acoustic waves, mechanical energy. And in the guideline, it gives you the recommendation, but if you go to the complete clinical practice guideline, you will have the listing of the studies to support your practice. I do want to point out one thing, and you'll notice on this page, here's a level A, and that's the top of the pyramid, correct? There are only 7 level A recommendations within the guideline. I always think of this because Dr. Joyce Black said this during our conference and during the launch. If there's only 7, shouldn't you really have some rationale why you're not doing it if it's a level A? So really think about it. Look through these. Throughout the presentation, we tried to give you the level of evidence. The level of evidence is very well defined, so you really need to think about it. Now, this one only has 1 arrow, so it's not as strong as 2 arrows, because you might think about it, well, maybe I don't have it available. So I just want you to think about it. Use the guideline to help guide your practice. Here's a nice table that the guideline does provide for you too, about the forms of biophysical agents. It talks about the category and outlines it quite well. I thought it was helpful, especially as you partner with your colleagues, especially physical therapy and your other wound experts that do some of the modalities if you don't do all of these. Okay, so what's next? Future technology. There was nothing in the guideline except saying it's coming, but I want you to think about the biosensor technology. These are flexible biosensors capable of monitoring some of the physiological information, but also assist in the treatment. So they laminate this device. They have different substrates, and how they integrate this biosensor technology into your dressings. So they have potential for promoting the tissue growth or the wound healing while simultaneously monitoring some of the wound parameters, such as glucose, pH, bacteria, blood pressures, temperature, interleukin-6, O2, and lactate. So I thought these were really interesting things to be on the lookout as your practice. The guideline comes out every 5 years. I'm sure in the next reiteration of the guideline and revision, there will be research related to these areas. And here's some examples, and you can go to these links and you can explore some of these new technologies. All right, so we've got a lot of ideas. We've got a lot of suggestions, recommendations, good practice statements, but how do we implement it? Well, the guideline is really more than just the recommendations. It gives you and provides you some resources to guide that implementation. Chapters 23 through 27. So 5 chapters devoted to helping you implement these recommendations. So do we continue doing it the old way, or should we look at trying something new? Here's just a reminder of the slide. I loved Dr. Cuddigan's slide. And the secret is the difference between research, but we need to adapt that intervention to the setting. So you might have the evidence, but if you can't do it or it's not available, maybe that's why you're not implementing it. You know, I always use the example of compression hose. We know that's a mainstay for the care of venous stasis ulcers, but if you can't touch your toes, probably not going to be too effective because you can't put them on. So thinking about your evidence-based practice and what is preference for the patient. So here are some of the best practices that we highlight in the guidance, in the guideline. And think about the Donabedian structure or method. Structure plus process equals outcome. So what are your structures that support that intervention? What's the process surrounding it? Because that's going to help lead to the outcome that you want. So put your thinking cap on. Think about what are your facilitators and barriers at the organizational level. Structurally, do you have leadership buy-in? Do you have an EHR that supports your work? What's your process surrounding it? Do you have a process around photography? If you don't, and people are just taking pictures when they want to, you're not going to be able to monitor progress. Here's another level A recommendation in the guideline that recommends a tailored, multifaceted quality improvement process. Don't shoot blind. When you're looking at all these recommendations, you say, oh my gosh, what am I going to do first? Well, you really need to talk to your quality improvement, to your leadership, and see what the priorities are. Identify a specific goal, and then you need to focus towards that. Don't do it all at once. Once you figure out what your goal is, and again, these are in the guideline, you need to engage your key stakeholders. Well, who are they? It's not only your leadership, it's all those caregivers surrounding it, your healthcare professionals. It probably is also your patients. Have you ever asked them what they prefer or what's important to them? And that's why this guideline is so helpful, because we did ask patients with pressure injuries and their caregivers, what's important to you? The other one is looking, are your policies and procedures and protocols evidence-based? Here's some of your structure and your process surrounding getting the outcome you want. Use clinical decision support tools. Do you have alerts and things built in to your EHR? Your leadership, that's you. Providing clinical leadership, stand firm. If you need to know the evidence, you need to know what's right, you need to know what's recommended. So stand firm, provide that clinical leadership to those around you. Educate, educate, educate. I know you say, well, education doesn't stick. Well, if you know 14% of your nursing staff is turning over, and every year you're losing that 14%, you need to have an education process in place. And you need to determine what's important that you need to focus on. Then again, you need to monitor and evaluate that performance and develop feedback and reminder systems. So here's your question for you. If you could implement one strategy, one pressure injury prevention or treatment strategy in your practice, what would it be? And I just put some examples here. But this gets back to that, don't shoot blind. Choose your goal. Where are you going to get the biggest bang for your buck? Do you need to focus on device-related? You know, device-related is typically almost 30% of pressure injuries occurrence. So is that something you need to think about? Do I need to focus on the OR? Did you know that up 20 to 30% or higher can be related to OR procedures? So again, think about where you're going to implement your new strategy. Where are you going to make a change? And now, as I conclude this session, I want you to really stay on and experience this virtual experience. And thank you to all our sponsors. And as they present some of the technology that is being used now for prevention, treatment, and detection. Thank you.
Hello, everyone, and welcome to the Abbott Nutrition portion of today's workshop. My name is Kathy Rominski, and I'm the Senior Manager of Professional Alliances and Education at Abbott Nutrition. And I'm joined by my colleague, Dr. Penny Davila Hicks, who is a medical science liaison with Abbott Nutrition and a dietitian. Dr. Hicks has her PhD in nutritional biology and is the manager of the U.S. Medical Science Liaison Team in the Department of Scientific and Medical Affairs at Abbott Nutrition. And we're so pleased to bring forth to you today a medical science dialogue, the evidence for nutrition in wound healing. And today's program is supported in part by an educational grant from Abbott Nutrition. So I'd like to begin, Dr. Hicks, with my first question. Can you take a moment, please, to review what are some of the latest updates in nutrition and wound healing, particularly related to practice guidelines?
Sure, Kathy. One of the exciting updates that we've had recently is that the 2019 International Pressure and Injury Guidelines have been released. And they were released in November of 2019. These guidelines include an entire chapter dedicated to nutrition. The nutrition chapter covers nutrition screening, assessment and care planning, energy and protein intake, nutritional supplementation, enteral and parenteral feeding, and also hydration. The guidelines also emphasize the importance of screening and assessing for malnutrition risk. They also advocate that patients who are malnourished or who are at risk of malnutrition should receive an individualized nutrition care plan.
So keeping in mind these guidelines, what is the relationship between malnutrition and wounds, and why is that so important?
The relationship between malnutrition and wound is very important. Multiple studies have shown that patients with malnutrition are at increased risk for pressure injuries. For example, the study that's shown here, for those patients that had a pre-existing condition of malnutrition or had weight loss after surgery, were 3.8 times more likely to develop a pressure injury or wound. The other important piece is looking at the prevalence of malnutrition. At hospital admission, the rates have been estimated to be 30 to 55% of patients with malnutrition. During this hospital stay, unfortunately, about a third of patients have nutritional decline. Following discharge, patients also can continue to lose weight, and that puts them at an increased risk of a readmission.
Understanding malnutrition is so important to patient care. Getting back to the NPIP guidelines, which nutrition interventions are recommended, and specifically what nutrients are most critical to the wound healing process?
So getting back to those guidelines, so that those 2019 NPIP recommendations address protein and calorie needs for patients with pressure injuries and malnutrition or at risk of malnutrition. So this at risk of malnutrition is new. Specifically, they state that for calories, you want to provide 30 to 35 calories per kilogram of body weight. And for protein, you want to provide 1.2 to 1.5 grams of protein per kilogram body weight. And this is for those adults that are malnourished or who are at risk of malnutrition. In addition to providing high calorie and high protein ONS, the guidelines recommend that patients with stage 2 or greater pressure injury receive supplemental arginine, zinc, and antioxidants. And this has been shown to improve wound healing. And these guidelines are for those who are malnourished or at risk of malnutrition as well.
So you noted the guidelines specifically highlight arginine. What is the evidence behind arginine and the mechanism of action? Can you explain that?
Studies with arginine have shown promise in increasing collagen, improving nitrogen balance, and enhancing immune function. Nitric oxide is also important for wound healing, and arginine is necessary for the formation of nitric oxide. Nitric oxide is beneficial in the wound healing environment because it's toxic to bacteria, can inhibit platelet aggregation, also can be an immune response mediator and neurotransmitter. Next, we'll look at the clinical data on arginine. There are 2 recently published reviews that we can talk about. So the first one is by Liu and others that was published in 2017, and it was a systematic review with 7 randomized controlled trials, including 369 patients. This review included both malnourished and non-malnourished patients with pressure ulcers that were stage 3 or higher. Now, the interventions that were looked at in this review range from 2 to 12 weeks. So what they reported was that there was a significant push score improvement following arginine-enriched enteral nutrition. And this was compared to the control formula with no arginine. And that push score, the pressure ulcer score for healing, was the primary outcome. They also found that the intervention was effective not only in the malnourished patients, but also in those patients that were not malnourished. If we look at the next study, also published in 2017 by Nyans and others, this was a descriptive review, and they included 7 randomized controlled trials and 4 clinical trials. Again, malnourished and non-malnourished patients with pressure ulcers stage 2 or higher. And the results were very similar. 10 out of those 11 studies showed a benefit of the arginine-enriched oral nutrition supplementation on healing of pressure injuries and pressure wounds.
That's an excellent overview, Dr. Hicks. Our attendees may be wondering, though, is there an additive effect of arginine in addition to protein and calories?
Sure. And the oligo-element SOAR trial is a study that we can talk about that describes this. So in this study, this was the largest clinical trial that was designed to look at the additive benefit of arginine and other micronutrients as well. So what they did in this study was have a control formula that was high calorie, high protein, with the intervention or the study formula that was also high calorie, high protein, but there was additional arginine added to that, where there was no arginine in the control formula. They also received additional zinc, vitamin E, and vitamin C, where in the control formula, there was some zinc, vitamin E, and vitamin C, but a higher level was given during the intervention or than the study formula. They were given 400 milliliters a day, so two servings a day for 8 weeks. And if we look at the results of the oligo-element SOAR trial, their primary outcome or their primary endpoint was the mean reduction in pressure ulcer area at 8 weeks. So they wanted to look at this through 8 weeks. They did have some secondary outcomes available as well. They looked at a 40% or greater reduction in pressure ulcer area at 8 weeks, complete healing, mean reduction in pressure ulcer area at 4 weeks, so the midway point, wound infections, and mean dressing changes. There was a statistically significant difference in the primary outcome that they were looking at of the mean reduction in pressure ulcer area at 8 weeks, where the intervention group, or those with the added arginine and extra micronutrients, had a 61% reduction, and those with the control formula had a 45% reduction.
The information you just reviewed is compelling. Are these interventions you've described cost effective?
The analysis of cost effectiveness was done during the oligo-element trial. There was a reduction in costs with nutrition interventions, and it was demonstrated in almost all parameters that were measured. They measured costs that were direct costs to that patient, such as nursing time, physician time, dressing materials, antibiotics that were used to treat wounds, pressure redistribution mattresses, tests, and overall costs that were direct cost. This was statistically significantly different, and there was cost effectiveness here. The data is shown in the quadrant here, where 95% of the data points are found in the quadrant that is more effective and less expensive. And this is also true for another outcome, one of their secondary outcomes that they looked at, with the reduction in pressure ulcer area of greater than 40%. But that's not shown in this graph here. But their primary outcome and their secondary outcome did provide cost effectiveness for this study.
So now I'd like to move into product solutions. So does Abbott have a product in line with the recommendations that you've reviewed today?
Yes, so Abbott has Juven, and Juven is a unique blend of key ingredients that is used to support wound healing. So it contains arginine, and we've discussed arginine, and we've discussed some of that research, but it also contains glutamine, and glutamine is an amino acid which serves as a fuel source for rapidly dividing cells, such as fibroblasts, macrophages, and epithelial cells. It also contains HMB. HMB is beta hydroxy beta methylbutyrate, and it's a metabolite of leucine, which has been shown to play a role in promoting protein synthesis and also reducing protein degradation. Juven also has hydrolyzed collagen protein. And hydrolyzed collagen protein is a rich source of proline that has been found to stimulate collagen secretion from fibroblasts, and it can improve, or maybe we should say reduce, the push score as compared to a placebo. Juven also contains other micronutrients that act as antioxidants. So it is recommended to use 2 packs of Juven per day to support wound healing. It comes in fruit punch orange and is also unflavored. Juven can be mixed with fruit juice or water, but it can also be mixed with different foods such as apple juice, ice cream, yogurt, applesauce, and a variety of foods and beverages so that you can change it up. Juven can be mixed ahead of time, and it's really best when mixed at room temperature. But one thing, Juven is not for IV use.
Thank you for that overview. So where can our listeners go for more information?
So our listeners can go to juven.com or abbott.com for more information.
Thank you for your attention, and that brings the Abbott Nutrition portion of the workshop to a close. Thank you.
Good afternoon. It is my pleasure to partner with the SAWC and the WHS for the first 2020 virtual conference on innovations in pressure injury prevention. So today I'm going to talk about dermatherapy by Standard Textile. My name is Annette Osborne. I'm the Senior Nurse Executive for Precision Fabrics Group. So I've been a nurse for 30 years and been involved in this research since 2008, so 12 years involved in the research of dermatherapy. And again, I'm a paid employee of Precision Fabrics Group. So what is the case for therapeutic linen? So in looking at this picture, which I love, it's a very old picture, but it shows that a lot of things in the patient room has changed. We don't wear caps anymore. That's my favorite. But what hasn't changed is the bed linens that the patients are on. Probably, in some regards, the cotton in that picture was probably a higher quality than what we have now. But the hospital bedding has changed very little in the last century. And we have used cotton bedding or 100% cotton bedding for some time, while everything else in healthcare has changed. So these cotton fabrics are designed to be a housekeeping item, to be bought at the lowest possible cost, and they have very little special properties. But interesting that healthcare spends billions of dollars attempting to prevent pressure injury and to improve wound healing, when the single item which is most intimate to the patient when you think about it is the actual bed linen itself and the patient gown. So what do we know about these implications? Well, here are some facts about that. We have 60,000 deaths every year. We have 2.5 million people that develop pressure injuries of some type in the U.S. every year in acute care and long-term care. These cases can cost as little as $43,000, but they are also considered never events for the hospital. So as a hospital-acquired condition, this is very costly to healthcare. And of course, many of us have information about lawsuits and settlements that are made regarding pressure injuries because many consider that pressure injuries are avoidable. So today I'm going to talk about how the latest international clinical guidelines from the NPIAP that were just released in November of 2019, how their recommendation can impact our pressure injury development and treatment by considering using textiles with low friction coefficients for patients or individuals with or at risk for pressure injuries. So how does that fit into our system for dermatherapy linen, and how can changing your linen become part of your therapeutic process? What we have designed is the next generation of healthcare linen products, and these products are engineered to perform certain things for the patient to optimize controlling the microclimate, which are all elements that actually cause skin to break down. So in looking at dermatherapy for this discussion, we're going to be comparing the dermatherapy therapeutic linen to the standard cotton or polycotton linen that's traditionally used in healthcare today. And what we like to say about dermatherapy is it's smoother, drier, it's cleaner, and it's cooler. And we know that all four of those factors actually play into the microclimate control that's necessary in order to promote healthy skin. So the one thing the linen can't control is the actual pressure. So the downward pressure that is experienced with every patient when they're sitting or lying on a surface. We know that we can put certain things in place to relieve pressure, but controlling the microclimate is actually something that's easier to control. And in using dermatherapy, you can actually improve the microclimate by reducing friction and shear and controlling for moisture and heat. The other unique quality about dermatherapy is that the way that it's engineered and woven, it actually is woven with a surgical grade antimicrobial. And that compound, Aegis compound, actually minimizes the bioburden on the actual textile itself. And we'll talk a little bit more about that. We know a lot about cotton already. And the quality of smoother, as it relates to cotton, the difference between dermatherapy is the way that it's woven. So it's a continual filament yarn is used, and it creates a much smoother surface. And you can see that in the photograph. That it's a microscopic view of the silk-like therapeutic linen that's on the left side of your screen, compared to the loosely weave of cotton. And you can see that on the right. And what happens when cotton is woven, it is organic, so it does take to stains very easily, but it also has a short fiber, and those fibers actually, as it is laundered, actually begin to peel and roll up. And when we've all had these types of cotton products, and what's interesting is that we actually develop strategies for those problems by creating cotton shavers and those kind of things to actually shave off those peels. And that is because those peels actually increase irritation and cause a rub to occur. So by having a continuous weave, it creates the fabric is more silk-like, which allows the patient to glide over the surface. It improves the quality of sleep and minimizes friction and shear that's happening next to the patient's skin. It is drier. If you look at the picture on the right, you can see that the yarn itself under a microscope actually looks like a cross-section of licorice. Licorice is the best example that you can see when you're looking at the filament yarn, and it actually creates a microchannel that wicks away the moisture from the skin. So when this happens, the evaporation actually takes place on the fabric instead of the skin, which means that the skin's going to be drier. And we know that wet skin is weak skin. And when you have weak skin, you have the potential for moisture-associated skin damage. And so having this evaporation take place on the textile actually creates a cooler and drier sleep experience and keeps the skin healthy. The cleaner aspect of the linen actually takes place in two arenas. So interesting that this weave and the way it's engineered limits the textile to lint, so it won't lint into the air. So you know that if you have cotton bedding and you fan that in the air, or you flip out a towel or something like that in front of an open window, you can actually see the particles in the air itself. And those are fibers that go into the air and could go into your open wound bed. So this type of linting actually is a mode of transportation for contamination. So by eliminating lint, you are eliminating the airborne particulate, And this actually is to the benefit of the patient to keep the wound beds free from bacteria. Also, because it is woven with the antimicrobial, it also decreases the growth of bacteria on the textile, which can have a very positive effect in reducing any type of hospital condition that relates to infection. Also, being organic, the cotton will retain odor, and by minimizing the bacteria, you also control for odor as well. And so you can see in both of the graphs that are listed, when you swab linen that has been in before and after patient use, you can see how the colony forming units are actually decreased on the dermatherapy. Keeping the patient cooler, of course, is great, and we all have experience with using engineered textiles to run in and exercise in that keep us cooler, but we have the science behind us to understand that a reduction of 1 degree Celsius in the skin temperature can actually have a very positive effect on the metabolic demand. And so in our patients that are most critical in the hospital, it's very important to control the metabolic demand for patients that are already compromised in some way. So keeping the patient cooler can be an advantage in taking care of those patients. In looking at the summary of this as a roll-up, I think it's important takeaways for dermatherapy compared to cotton is that it does reduce friction by 35%. It wicks away moisture, dries quicker. It reduces the metabolic demand, eliminates lint, and also reduces the bioburden on the textiles by using a surgical grade antimicrobial. What does this mean, and how is this important to how we practice and create the standard of care for patients? Well, we have used dermatherapy in several clinical trials that have been peer-reviewed and published. The one that I'd like to share here is a study that was done at the University of Michigan in the critical care and surgical intensive care, and was published in the American Journal for Critical Care in November of 2017. What was interesting about the study is that they looked at posterior pressure of patients coming out of the OR, and they were able to reduce 62 posterior pressure injuries, which also had a very positive effect on their length of stay in the ICU, resulting in a $3.9 million reduction in cost. This study is a wonderfully done study where they also looked at the lifespan of the linen and had their savings actually certified by their financial partners. So in looking at publication, there's lots of publication about this particular technology. So we have studies that were done in acute care, critical care, long-term care. Those actually resulted in our FDA clearance, but also gave us evidence for the NPIP, International Guidelines, and most recently, the MORE study was actually a demonstration project where we actually deployed the linen to home care. We deployed it with patients that qualified for a hospital bed at home to use the linen there, and we have an abstract that was actually accepted by the JWOCN for the conference that was just held, and we have a printed manuscript for that. So stay tuned for how the application will look in home care. So looking at the research then, it puts dermatherapy in a really unique position. With all these credentials, it really separates us from cotton by having the published clinical trials with outcomes and recommendations from the 2014 and 19 NPIP, and also gives us enough evidence to have FDA clearance as a Class 1 medical device with the likelihood of reducing pressure injuries by controlling the microclimate. Now, having a textile that is a medical device means that it's not an apples-to-apples comparison anymore to cotton bedding, because cotton bedding has no special qualities. And a medical device, of course, has a proven clinical result. So, of course, the value propositions that we've already talked about reducing hospital-acquired pressure injuries and reducing bioburden, and hospital-acquired infections are all part of the value proposition. But of course, the other value is in other things that you may not think about, which would be improving the existing skin issues for the patient, because the fabric also has a 510K showing its effectiveness against atopical dermatitis and eczema and psoriasis. Also, we have found that there's a ease of moving and repositioning patients, which improves overall bed mobility and independent functional mobility for patients. By improving bed mobility, you also have an impact on workers' injuries and workers' comp claims. We also, by having reusable underpads, and this fabric is very durable, it also lowers the cost per use, eliminates straw sheets, and eliminates the disposable waste. So, of course, I'm very excited to be able to have this opportunity to share with you. It's very interesting to have an innovation that you can potentially just change your sheets and improve patient care. But if you have additional interest, I would please call or email me for samples or additional research, and I would love to spend more time talking about this innovation. Thank you to the SAWC for this opportunity.
EHOB was founded in 1985, specializing solely in pressure injury prevention. For the last 35 years, we have strived to provide simple, clinically proven, cost-effective solutions. Our focus is to deliver solutions and educational services to meet the needs of the patient, clinicians, and healthcare team. We are committed to improving patient outcomes and workplace efficiency every day. We see each day as a new opportunity to make something of value, and we have learned this along the way. We do it better together. Christy Sprinkle, EHOB's Associate Director of Clinical Affairs, is pleased to present practical education on EHOB's pressure injury prevention solutions during the SAWC Pressure Injury Workshop. We thank you for the opportunity to provide education on the following 4 pressure injury prevention solutions designed for single patient use across the continuum of care. EHOB's reactive air pressure redistribution support surfaces, the waffle overlay and waffle cushion, are designed to redistribute pressure at bony prominences for the prevention and management of pressure injuries. The TrueView Heel Protector is indicated to properly offload the heel for the prevention and management of pressure injuries and deep tissue injury to the heel. The ATR Plus is a multi-component system that provides caregivers a safe and easy way to manually turn and reposition patients, while properly offloading the sacrum for the prevention and management of pressure injuries.
Hello and welcome to the Hillrom section of the session. My name is Sean Tomini. I am the Senior Marketing Manager for Hillrom based in our Chicago, Illinois office. As far as disclosures, we just need you to know that support for this activity was provided by Hillrom and that I am an employee of Hillrom working in our marketing department. So today we're going to be talking about a new innovative piece of technology that's called the WatchCare Incontinence Management System. We want to show you how this new technology works, but we're going to start by explaining some of the clinical rationale behind the problem that this incontinence management system is designed to address. And so the first few slides that we'll talk about, and it's kind of the first piece of kind of clinical support behind it, is from an article that was published in the Journal of Endoscopy Incontinence Nursing by Dr. Gray in 2018. And it looked at incontinence and how common of a problem it is in the acute care setting. And what Dr. Gray and his co-authors looked at were actually a really large number set, a really large data set of incontinence evaluations that were done in the acute care setting. It actually included over 5,000 patients from hospitals that were represented across 36 different states within the US. So a really broad, really large sample size. And it was really compelling data that hadn't really been shared it's probably been about 4 years prior to this publication before we had a really robust data set defining the problem of incontinence-associated dermatitis and the scope and scale of it in our US hospitals. So what Dr. Gray and his colleagues found was that at any given time, somewhere around 47%, the actual number in the article is around 46.6, but around 47% of patients are incontinent at any given time. And this was across care settings. So you had some med-surg, you had some intensive care units, really everything was, all the areas of an acute care hospital were represented. And so we find that we have about half of our patients are incontinent at any given time. And when we think about the amount of work and the amount of investment that's been done over the last few years to address skin integrity and challenges around hospital-acquired incontinence-associated dermatitis, it was really surprising in this data set to find that around 45% of those incontinent patients were acquiring incontinence-associated dermatitis during their hospital stay. So this is starting really to emerge as a problem that is becoming more complex, certainly over the last few years, as hospitals have gotten more aggressive with removing Foley catheters in response to the CMS initiatives around CAUTI prevention. And so we're seeing a lot more incontinence within our hospitals, and we think we're seeing, this data would suggest that we're seeing an uptick in the amount of incontinence-associated dermatitis that we're seeing. Many of you are probably aware of that problem, but some of you may be thinking, well, what's the relevancy to me as far as my practice within the hospital? Kind of the so what of incontinence-associated dermatitis. We know that CMS and the NEVER events right now and the value-based purchasing is all focused on stage 3 and stage 4 pressure injuries, but there's a direct correlation between those patients that have IAD in that it functions as an independent risk factor for pressure injuries. There's a few different published numbers out there, some as little as 3 times greater risk, some as high as 6 times greater risk. And if you look at that risk stratification, that IAD functions as an independent risk factor. And that's important in that understanding that even if we're doing all the important elements of a pressure injury prevention bundle, that IAD stands alone as an independent risk factor that leaves your patients at as high as a 6 times greater risk for hospital-acquired pressure injuries. But the other reason that we really think that incontinence-associated dermatitis and the management of urinary incontinence is important is because it really complicates everything else that our caregivers are trying to do. And so if we look at our sort of stages of pressure injuries, and if you see on the screen moving left to right, we see a stage 1 through a stage 4 sort of full thickness pressure injury. Although, we certainly want to make sure that we're not seeing these hospital-acquired pressure injuries even if we do have a stage 1 or a stage 2 that's present on admission, we know that dealing with incontinence and introducing incontinence into that area of the patient's body is going to complicate everything that our wound care teams are trying to do with healing and treating the existing wounds, even if they're present on admission. So whether it's present on admission or hospital acquired, the complexities are greater when we're dealing with a patient that has incontinence. And so as we thought about this problem of incontinence, it was important for Hillrom that we get the nurse's perspective on how the current standard of care is unfolding in our hospital environments. And so we did a survey of over 400 nurses from the acute care hospitals, and we wanted to figure out sort of what is the standard of care right now around managing incontinence in the hospitals. And what we've learned was that hourly rounding is considered the standard of care when it comes to trying to manage incontinent patients for risk of skin breakdown. And what we found for that research was that rounding does not necessarily address all of the problems around incontinence, and that incontinence inherently has a negative effect on their ability to do hourly rounding. And so if you think of that as a story or as a scenario, how that plays out in our hospitals, if I'm a nurse on a med-surg floor, I could have 6, 7, possibly 8 patients that's under my care. And if I start hourly rounding on Mr. Smith in room 1, and I come in and I check Mr. Smith and everything's fine with him, when I leave the room, inevitably, right, Murphy's Law tells us we're going to have an incontinent episode with if he's an incontinent patient. And at a perfect case scenario, we're not going to round and get back to Mr. Smith for an hour. And what we know is that in our med-surg environment, with all the things we're asking our staff to do, and those patients are becoming more complex over the last few years, that in that environment, hourly rounding is really hard to adhere to. Everyone tries, they put forth their whole effort, but it's really hard to adhere to that hourly rounding. And in this research that we did, in these surveys, the nurses that we talked to said that they begin to worry about that patient within 10 minutes. So if you think of that scenario of hourly rounding, there's nothing about that process that's going to get that nurse over to that patient within 10 minutes of an incontinent episode when they start to worry about the patient experience and the skin health. The only way that that process gets disrupted is if a patient were to self-report. They have to hit the button and call for help. And when I think about that scenario, I often think of my own father. He's a 72-year-old retired auto worker from Northeast Ohio, and the chances of him hitting a button and telling a 22-year-old nurse that he's wet the bed are very, very low. However, what he will do is he'll sit and he'll talk to my mom about it, and then they'll fill out their patient satisfaction survey together. And so now we're in a realm not just of care, but we're in a realm of real patient satisfaction and the perception of care within our hospitals. And it's real important as we talk about the workflow within nursing right now. One of the sort of things that I always try to touch on when I'm talking to a group of nurses is to understand that we're not really indicting the caregivers. We want to indict the process of how we routinely monitor for incontinence currently. A lot of these clinicians want to get to that patient within 10 minutes. They just lack the information that they need to prioritize care. We'll share an outcome with you a little bit later that really demonstrates what the nursing staff will do in response to having good information around who's incontinent and when they're incontinent. But beyond nursing research and surveying nurses, we also wanted to look at more clinical, sort of quantitative data as well. And so the next piece that really helped us along this journey was a poster that was published by Leanne Phipps. It was presented at last year in the 2017 National Pressure Ulcer Advisory Panel Conference. And what it did was it was lab data that looked at healthy patients that came into the lab environment. They introduced synthetic urine onto a hospital surface, and they did introduce that synthetic urine onto a breathable, moisture-wicking, high-performing underpad. And then they placed the subjects on top of that underpad. And they took checks of measurements every 15 minutes, 30 minutes, an hour, and on down the line. And what they found was that within 15 minutes, the two biggest indicators of initial skin breakdown started to demonstrate that we were having skin be affected within 15 minutes of a single event. So certainly the pH level of that skin was raised, but also the measurements, sort of the physical measurements against the skin, the friction force, the shearing force, those things were measured, and was found that the introduction of incontinence exacerbated both of those issues. And actually within an hour, 70% of those healthy subjects had visible skin irritation within 1 hour. So now if we go back to that model of understanding hourly rounding, we start to look at what is this idea of exposure time? What is an acceptable amount of time that a patient is left exposed to an incontinence event? And so the nurses that we surveyed would tell us 15 minutes. This data from the lab environment tells us 15, 20 minutes, certainly less than an hour. We want to make sure that those nurses are able to intervene and get that incontinence off the patient. And so Dr. Gray, in a number of writings, sort of helped us understand that incontinence exposure time might be one of the critical factors that a lot of research hasn't looked at. And so our goal with this incontinence management system is to try to close that gap, to make the time from the pad gets wet until the time that the pad becomes changed and is dry. We want to calculate that exposure time and try to influence it to close that gap as tight as we can to that 15-minute goal. And so I'm going to share an outcome with you that will help show what this technology does once it's in a care unit. But I want to give you a very top-line understanding of what the technology is. So the WashCare Incontinence Management System is basically comprised of 3 elements. There is monitoring technology that can be installed to the patient bed. And so these are sort of an array of antennas and data processors that get mounted to the deck of the bed under the mattress or under the patient's surface and are more or less out of sight from both the nurses as well as the patient. The next part of that system is a moisture detecting smart pad. And so you'll see in a video here shortly that shows it in more detail. It's all the elements that you would expect from a high-performing, moisture-wicking, breathable underpad. It's absorbent, it's strong, it protects the patient's skin, but it has one thing that no other underpad has, and it's this moisture-detecting technology, which is basically lines of conductive ink that are connected to an RFID chip embedded within the smart pad. And once moisture crosses those lines of conductive ink, the RFID chip alerts the monitoring system that's mounted on the bed, and it provides information to the caregivers. It's really that information which is the valuable piece of this whole system, in that the information, once provided to the caregivers, is going to change the amount of exposure time that those patients are left to. What we know about our nurses through surveys as well as through the clinical piece I'm about to show you is that our nurses want to do the right thing. Our caregivers, our patient care techs, our nursing assistants, everyone on that unit wants to address those issues in a timely manner. But if they don't have the information to prioritize care, they're left to use hourly rounding. And what they're really doing is stumbling upon incontinence during rounding rather than being proactive and responding to the information of when a patient's wet, where that patient is, and they can get to them quickly. So that's the information. That information is provided really in a number of ways. There's a discrete silent light, so a silent alert, just a lighting system at the foot of the bed that pulses and shows that an incontinence event has happened. And then that information is also pushed out through the nurse call system to maybe a dome light, a status board, and even go to a handheld communication device that the nurses are using. All of that information enables them to prioritize care. And this is what that prioritization of care looked like in one unit. So again, this is a poster, was presented last year at the American College of Wound Healing in Chicago. The project was completed at Dartmouth-Hitchcock Hospital. It was on a 36-bed unit, a very typical med-surg unit, laid out over 5 months, covering over 1,500 incontinence events. And what this team did at Dartmouth is they installed this watch care and continence management system technology onto their beds. But in order to set a baseline of exposure time, they blinded that technology. So they covered the indicator light at the foot of the bed. They didn't turn on the notification systems. They gave very minimal education of the nurses, just letting them know that they had a new kind of underpad that they were looking at. They used the technology, which has the ability to timestamp and record when a pad's wet and when that pad gets changed. So that's how we established the measurement of exposure time. And what they found was over 54 days, that average exposure time was 123 minutes. So over 2 hours of average time from wet pad to dry pad. After that first 54 days, we went into the unblinded section where they took the covers off the lighting system, they turned on the nurse call system, and we did a full in-service and education for the nursing staff on that unit. And what we found in that period of time over 93 days is that exposure time went down to an average of 18.9 minutes from wet pad to dry pad. So we see going from 2 hours down to 19 minutes. These numbers were statistically significant. We will be submitting this for publication into the JWOCN, so you'll see this in the journal hopefully this year. And beyond the numbers and looking at the exposure time, we also got very positive feedback from family members once they knew what the system was. And most importantly, we really benefited the nursing staff. So you see the quotation there that nurses felt more confident in the resources that they had so that they could practice the best class incontinence care that they know they're supposed to do. So that's why we think of this as the watch care and continence management system as providing information that elevates care. What we prove out with this study is, one, our baseline exposure time was probably a lot more than really that team thought going into this project. And what we do also find is that the nurses, when given that information, they will utilize it to provide a better level of care. And so it's real important that when we talk about this stuff, we talk about indicting the process of incontinence rounding, not the caregivers that are providing that care. Because what we see by this study is that if we give them that information, they'll certainly do the right thing and take care of their patients in a really elevated way. So we see from this that we impact not just the workflow and the efficiency of the work, we also have a positive impact on the patient perception of care, patient family member perception of care, and we left the nurses feeling that they were empowered and that their perception of the care they were delivering was better through the use of this system. So that's really the clinical story and some of the impacts you might expect to find when using this watch care and continence management system. We're now going to show you a video which takes a nice deep dive into how the technology works, what it looks like. It'll give you a sense of what the smart pad technology looks like and what the hardware that goes onto the bed systems looks like as well. So thanks for taking the time today to learn more about this system, and hope you enjoy the video and get a deeper understanding of the watch care and continence management system. Thank you.
The Watch Care Incontinence Management System is designed to protect patients' skin, improve patient experience, and optimize caregiver effectiveness. It detects moisture from urine and liquid stool and provides a discreet and timely alert that may minimize the skin's exposure to incontinence and address an independent risk factor for hospital-acquired pressure injuries. The system has been designed and tested for compatibility with the following beds and their compatible Hill-Rom mattresses. The Watch Care system is comprised of 4 major components. The Watch Care Smart Pad is a radiolucent, absorbent incontinence pad that uses conductive ink and a radio frequency identification tag to detect moisture and notify a Watch Care-enabled bed that an incontinence event has occurred. Watch Care antennas and readers are installed once and can be retrofitted to existing beds in your facility or added to new Centrella or Progressa beds upon delivery. The 4 antennas are located under the mattress, and the reader is located on the frame of the bed. These components enable the bed to communicate with the Watch Care Smart Pad. VersaCare and Progressa beds will include a dedicated Watch Care indicator light at the foot of the bed. Centrella Smart Plus beds will include a WatchCare indicator light as part of the Safe View Plus system. All indicators use multicolor lights that indicate the system status. A solid white light identifies that the monitoring system is on, but no SmartPad is detected on the bed. A solid green light identifies that a SmartPad is recognized. The system is actively monitoring for incontinence and the SmartPad is dry. A flashing amber light identifies that the SmartPad is wet. When using the SafeView Plus system on the Centrella bed, the green and flashing amber lights will project on the floor. Progressa and VersaCare beds use a 1/4-inch communication cable to connect to the facility's equipment call jack. Centrella beds use one of two options to connect. When using a Hillrom nurse call system, a SideComm cable connects to the bed and to the facility's 37-pin connector. When using a different nurse call system, connect the 2-cable end of the WatchCare adapter to the bed. Then connect the pin end of the adapter cable to the facility's communication cable. Next, connect the remaining 1/4-inch cable connector to the facility's equipment call jack. Ensure the bed's power cord is plugged into a power outlet and connect the applicable nurse call cables at the head wall. Place a SmartPad in the middle of the bed, using the bed's hip indicator for reference, with the head icon towards the head of bed and foot icon toward the foot end. Listen for a single beep and ensure the indicator light has turned to indicate that the pad has been recognized and the system is monitoring for incontinence. The system is designed to alert when the fluid absorbed into the SmartPad crosses 2 lines of conductive ink. The system will always alert at a volume of 180 milliliters, but could alert as low as 20 milliliters. The SmartPad's total capacity for absorption is 1 liter of fluid. Unused clean pads should be stored at least 2 feet from the bed to avoid the system inadvertently recognizing the pad. The WatchCare system can monitor up to 4 SmartPads at one time. However, Hillrom recommends minimizing the number of layers under a patient. Placing devices that contain metallic components or metallic materials, such as a chair exit pad, under or on top of the SmartPad could interfere with incontinence monitoring. The indicator light at the foot of the bed flashes amber to indicate an incontinence event has occurred. No audible alerts are generated at the bedside in effort to maintain patient dignity. If using a nurse call system, depending on the system configuration, alerts may also be sent to the nurse call console, the nurse call dome light over the door outside the patient's room, the applicable mobile devices available at your facility. Hillrom recommends that these alerts be configured to be silent and utilize visual cues only. Any alerts generated by the system can only be canceled or turned off by removing the soiled SmartPad and replacing it with a clean SmartPad. Remove the soiled pad and discard it at least 2 feet from the bed to ensure the reader no longer detects the soiled pad. Place a new SmartPad on the bed. To ensure the new pad is being monitored, listen for a single beep. Also check that the indicator light has turned green. In the event that an alert is activated, the soil pad is removed, but not replaced by a clean pad. The alert may persist for as long as 10 minutes before turning itself off. For additional details on using the WatchCare incontinence system, please refer to the product user manual.
Well, thank you all for attending this virtual workshop through Medela. My name is Dr. Anthony Tickner, and today we will be discussing a few different things with the Medela VAC. Again, I'm Anthony Tickner. You can see I'm the medical director at St. Vincent Hospital. So just a quick disclosure, support for this activity is in part by Medela, and I am a consultant for Medela. So today we're going to be talking about, is your negative pressure working for you across care settings? So this is a quick quote from Tony Robbins, and basically the gist of it is saying that change happens when the pain of staying the same is greater than the pain of change. And nobody likes to change. Nobody likes to change what they're doing. We like to, get set in our ways, and we really rarely want to stray from that path, but sometimes change is good. So is it easy for healthcare professionals to care for their patients with negative pressure wound therapy? Well, yes, it is, and that's what we're going to discuss today. And we've got some cases towards the end, and you're going to see the technology, and you're going to see the healing potential in different types of settings and different types of pathologies and different types of indications. So the criteria for choosing negative pressure wound therapy is, do you have the experience? Is this a new company, or is this a company that's been proven, and is the support there? Can you call somebody and get a live person? Is it easy to apply? Is it reimbursable? Does your area support this type of device? Does your area support the reimbursement? So these are all very important things to look at, and to make sure it's not something that's just quote unquote cool, but it's something that's actually going to work, and it's something that is actually going to give you the benefit and the ease of use and the the patient satisfaction. So that's all very, very important. So we look at negative pressure with a mechanical feedback system, and the system we're discussing today, the Medela line, is very, very intelligent, because we have this double lumen technology where we're actually able to get intelligent pressure control going into the system and into the fit pad, as you can see there with the control lumen. And then as we're removing exudate and we're removing debris, we're able to take that out of the wound and out of that fit pad and remove that out of the area and into the canister. So some of the indications for the system are acute or subacute wounds, chronic wounds, dehisced wounds, pressure ulcers and injuries, diabetic and neuropathic ulcers. As you can see, there is a long list, and this is similar to a lot of other systems. But what I have found is this system in particular is very, very efficient, very, very good for patients, and decreasing pain levels and compliance, and also the system is quiet. We'll be focusing more on pressure ulcers and injuries, because it's helped me tremendously with my difficult patients and their situations. So if we look at the dressing kits with the fit pad, we see that we've got a lot of the things that you are comfortable with, that you are used to. And if you look at the gauze, if you look at the foam dressing and the transparent film, that's something you're going to be very, very similar and familiar with, depending with any type of unit you're using. So that's going to be pretty much similar across the board. And they also have a nice gauze pad dressing, which is very helpful as well. As you can see from the diagram, the last two boxes, you've got that quick connector, you've got that tubing attachment. So that is very easy to hook and unhook and attach and detach without removing everything from the wound. It's nothing worse than having a nice suction seal and you've got to remove everything because there's beeping or there's something going on. So this is a quick release, quick connector system that helps. So let's look at a few cases. And again, we're here to talk about pressure injuries and pressure ulcers, but you're going to see that this not only works for those indications, but also works for other situations. But primarily, this has helped me tremendously with those types of issues. So let's look at some cases. Our first case is a patient who presents to the hospital with after a right hallux amputation, and social history you can see there, and the wound presents with no signs of infection. Again, here on the side, comorbidities, we've got osteomyelitis, diabetes, basically the laundry list of everything that we see with all of our patients. So we look at the case progression. In the initial presentation, the wound isn't that large, but it is over a pressure area of the foot, and this is an area that takes a lot of beating, and the patient is neuropathic, so they don't feel it. And you can see the wound is 1.6 by 1.5 by 0.2. We actually had to take this patient to the operating room, remove a lot of that bone because there was osteomyelitis. And another take-home message is don't be afraid to make the wound bigger in order to heal it and to make it smaller with your negative pressure therapy. So after surgery, you see that wound goes from that 1.6 times 1.5 times 0.2, and actually we're making it a little bit bigger. So now it's 4 by 1.5 by 3. And after 8 days of back therapy, we see that the wound is starting to respond. It's starting to want to close up a little bit. And you see after less than 2 weeks, we're getting good granulation tissue in there. And just after 14 days, we get a dramatic reduction. And this is at a pressure of negative 125 millimeters of mercury for 3 times a week. And we see here from the graph, we've only instituted the negative pressure for a short period of time. And automatically, from the graph, we see the volume and the area are dramatically decreasing in that 2-week period. So we see after 14 days on therapy, with that original pressured area, we've got almost a 60% reduction in the volume. And that patient went on to heal. Case number 2 is a patient who presented to St. Vincent Hospital with after resection of the 4th and 5th rays with a graft. This is a patient that stopped smoking 2 months before the visit and denies any alcohol or drug use. The wound presents with erythema, edema, and serosanguineous drainage, but no odor. Again, diabetic, osteomyelitis. So with this case, we see the initial presentation. You see that that's a fairly large wound, and that is the post-surgical view of the resection of the 4th and 5th rays. And that is a highly pressurized area. It takes a lot of abuse, and you see we start to get that cleaned up, and we institute the negative pressure. And right here at 0 days on therapy, we're looking good. We're ready to receive that negative pressure. And you see after 7 days, the wound is decreasing in size in all directions and depth as well. 14 days and 19 days, you have also continued dramatic decrease in volume and area. And again, the prescription for that was negative 125 millimeters of mercury 3 times a week. We look at the graph and we see where the negative pressure was applied, and we see where we stopped it. And what you'll notice with a few of these cases is that we didn't need the negative pressure from beginning to end of the life of the wound. And that's very, very important. And it's a testament to the potency of the negative pressure, because we actually needed it for a very short period of time. I've had patients that had negative pressure for a little bit longer, and these were just very, very dramatic cases with highly pressurized areas. So we see from the application to the stoppage of the negative pressure, a dramatic decrease in volume and area. So 19 days of therapy, just under 3 weeks, we have 124% reduction in volume, and the patient went on to heal. The last case is a patient who presented to the hospital with a non-healing plantar first metatarsal head ulceration. This is a patient that drinks alcohol, a former smoker. Again, the wound, the presentation at the time presented with erythema, edema, and some drainage. This is a patient like many of our patients who's diabetic, hypertensive, neuropathic, and there's a few of the medications listed. So we look at the case progression for this patient, and we see the initial presentation is not a very large wound, but this is also a patient who had a lot of friction, had a lot of forces to this area, and a lot of pressure to the area. He couldn't feel a thing. He developed almost like an abscess in that area, a soft tissue mass, and that's why you see that it looks somewhat bulbous in that initial presentation. So the wound itself is not that big, but the area around it is very fluctuant. So we see that we need to take him to surgery as well, and you see 0 days on therapy, and this is after the operating room, and we had to clean everything out and remove basically a soft tissue mass, and we get the negative pressure instituted, and you see after 1 week and then after 14 days, all that area that was initially had more depth and more basically structures involved. We see that after 2 weeks we've come up in our in the depth almost to skin level, and there's no more tendon exposure, which we see on 0 days on therapy there. And again, the prescription was the same. So if we look at the graph again, when the application of negative pressure was applied and when the negative pressure was stopped, we see that the area and the volume are dramatically decreased. And a lot of you out there may be using negative pressure and saying, okay, well, I use it at negative 125 and I haven't used anything else. If you have a highly draining wound, or if you have an area that's taking a lot of forces and a lot of exudate is being removed, then you may want to think about increasing your pressure, or you may back off if the patient is complaining that they're having too much pain or discomfort. So it's not uncommon that we would use the settings at 100 or bump it up to 150 to get added removal of exudate. So the case progression for that last case with that soft tissue mass, we see at 14 days we've got a really, really high reduction in volume, and that patient also went on to heal. So why is it easy for clinicians to use negative pressure on their patients? Well, you have to be confident that you're going to get that technical support and that clinical support, and that your area is going to cover this type of device, and that it's tried and true, and it's not a fly-by-night company, and you have the people that are working with you and for your patients, more importantly. So you're going to get all of that bundled into one. Now we look at the devices, and we've got a larger unit, which is actually very still small in the negative pressure arena. It's only 2.2 pounds, and it holds a ton of exudate, and it removes a ton of exudate, and it can go anywhere from 300 to 800 mLs in its canister, and it's got a long lasting battery, as you can see. There's also a handheld smaller version, smaller device. So the larger device is the Liberty, and the The smaller device is the Motion, and that is under a pound, and that obviously doesn't hold as much in the canister, but still holds a good amount at 150 mLs, and a long battery life as well. The good thing about the Medela line of negative pressure is there's really no change in pressure or in the suction capabilities of the devices, no matter where you put them. So if the patient's lying flat on their back in the bed and you've got the unit 3 feet or above them or 3 feet below them, all the studies and the literature have shown that you're still going to get that that constant pressure. And so that this setting, it's negative 125. And like I said, the studies have shown that you're still going to get that. This is just a quick little diagram showing that, you know, the standard of care and then the Medela settings here, you're going to get very high volume and viscosity. It's going to cycle through a lot more if you've got a highly exudative wound compared to a medium or a low type of wound that has less exudate and less debris. So you're going to have that dynamic adaptability where you can get up to 20 times in every 5 minutes. So that's something to think about when you're thinking about your patients and you're thinking about how much you want to get out of that wound. You don't want it to be stagnant. You don't want the pump to just be sitting there. You want it to actually be working for you and for your patient. So the support, like we mentioned before, you've got QR codes, you've got an app that you can use. There's clinical and technical support 24/7. Very, very wonderful quick access cards, a lot of resources on the internet. So what did we learn? Change is good. Ask why. Make negative pressure work for you. Have fun doing it. Again, we went through the indications early on in the presentation, and you know, if you've got those patients with those difficult pressure injuries, pressure ulcers, and DFUs and everything else, this is a system that has worked great in my practice and in my busy office and wound care center, and it's definitely worth a second look. And if you're interested, all the information is available.
Well, hello, everyone, and thank you so much for being a part of this symposium. And thank you so much to the SAWC and its chairman for inviting me to provide this lecture. My name is Todd Brindle. I'm the United States Medical Director for Mölnlycke Healthcare. And this is a Mölnlycke sponsored symposium. Before my role with Mölnlycke Healthcare, I did spend over a decade at a level 1 trauma center in the United States, where I was the clinical lead in collaboration with my mentor, Sue Crehan, to help direct the pressure injury prevention program at a large level 1 trauma center. And so that is my frame of reference from this talk. But what we want to do today is, you've already heard this fantastic lecture presented by the NPIAP introducing their new international clinical practice guidelines. And I think all of us struggle when we look at the amount of time and effort and evidence that went into this document. I think we all know if we take that book and we set it on our shelves in our hospital, it doesn't necessarily translate immediately to reduced pressure injury numbers and incidents. And so what we have to decide as a facility is, how do we take these evidence-based guidelines, these clinical practice guidelines, and implement them? And what I'm going to do today is also, when you're looking at different vendors, when you're looking at products to add to a pressure injury prevention program, how do we use how do we match evidence-based guidelines and evidence-based practice to the interplay of evidence-based dressings to support pressure injury prevention? What I'm going to do is, there's so much information in the clinical practice guidelines, and what I decided to do is actually reference another study that was published in the Journal of Clinical Nursing by Dr. Bill Padula and Dr. Joyce Black, and they've thankfully, and thank you to them for allowing me to utilize their publication as a reference, because what they did is, when you're staring at this huge clinical practice guideline, a lot of facilities ask, where do I start? And what they've done is combed the evidence to say, what about these clinical practice guidelines, or what features in a pressure injury prevention program, if you implement them and you implement them well, will provide, an immediate impact on your quality outcomes. And so they published the Standardized Pressure Injury Prevention Protocol, or SPIP checklist. And we're going to go through very briefly some of these 6 key factors that they say if you focus on, you can have an impact on your pressure injury incidents in your hospital. And what I want to be very clear on is that while they've given me permission to use this publication is product agnostic. And so what I'm going to try to do is present what they suggest as far as an implementation plan, and then look at how our products or implementation of evidence-based products will match that. So I just want to be very clear that this is not an endorsement by the authors for any of our products. One of the things that we see is that when we look at transforming pressure injury prevention across an organization, is there's a need to look at the way that we have to implement prevention as it relates to an organizational-wide culture change, and also how do we look at setting up specific protocols or bundles for a unit-based approach, and then also how do these products directly mitigate the impact of pressure and shear at the patient level. And so Dr. Padula references the Donabedian model of structure, process, and outcomes. And so I want you to keep that idea in mind, that when we approach pressure injury prevention, it's on a hospital level, it's on a unit level, and then we have to understand how to approach prevention at a patient level. So the very first key of the 6 points of the checklist, the very first one they talk about is education and onboarding. And one of the key features that they start with is you have to engage senior leadership. And you do so by utilizing data through monthly outcome reviews to have that mutual accountability of what does our data say our problems are, where are they located, and where can we identify gaps in our implementation of best practice guidelines and in order to achieve outcomes. And while we need wound champions to lead this initiative, and while we understand that we have to have experts in pressure injury prevention to guide us in this program, we can't do it by ourselves. No one nurse or nursing group is going to turn the tide for sustainable pressure injury prevention. And so they really talk through, documenting outcomes and utilizing quality measurement in order to guide where we allocate resources and we guide the implementation of best practice guidelines. So data tracking is absolutely vital, not only for that resource allocation, but return on investment. Because remember, the procurement team has to be a part of this pressure injury prevention group. They have to understand, and we have to use data to identify what products have evidence in order to achieve clinical outcomes. But more importantly, when we select a product out there, how do we know that we're not only getting the clinical efficacy, but we're actually able to demonstrate a return on investment, again, using data. And it's something via courtesy of Sue Crehan's work. In the past, we're seeing actually some data from a level 1 trauma center here, where the red line indicates the national prevalence of pressure injuries, and then the blue line looks at the facility-specific data. And what you can see is very true from what the authors talk about with education and onboarding. The more we teach, the more we educate on how to prevent pressure injuries, we end up finding more. The more you look, the more you find. And so every time we focused on a specific aspect at that unit level for pressure injury prevention, you'll notice that the blue line spikes. And that's an indication that education will lead to increased capture of those pressure injuries. But more importantly, when we look at some of the research that was done in the past, especially in regards to Meplex border sacrum and that MBS on that slide, you can actually see how when we implemented that, the data allowed the facility to recognize not only the clinical efficacy in reducing pressure injuries, but more importantly, that data could be demonstrated to procurement to help them understand that there was a return on investment in terms of that prevention of the pressure injuries that used to be forming in those respective areas of the hospital. So we have to use data to our advantage. The second key checklist item is risk assessment. And I think we do this pretty much across the board very well as far as on admission, upon readmission, and change of condition. But what's really important to not only sustain pressure injury reduction, but also protect yourselves from the risks of litigation is the importance of documenting when you put forward interventions and you escalate those interventions to match risk. For example, if we have a risk assessment scale that shows that our patient's risk is at 16, for example, and we have a program or a bundle of pressure injury prevention in place, yet their risk drops, we need to see corresponding documentation of new interventions that are in place to match that changing risk. And so as an example of that, when we have an ICU patient, where maybe in the ICU we've already put forward a bundle with low air loss mattresses and other preventative items, this patient specifically has ECMO and an IJ ECMO placement, where we have to really concern ourselves now with the individual risk of the patient, maybe his body being able to be turned, but limited mobility of the head. And specifically also, how do we prevent against device-related pressure injury with that very rigid cannula? And so this is where, with our evidence, when we introduce evidence-based products like the Z-Flow Fluidized Repositioner have the ability to mitigate that pressure and shear. And more importantly, when we look at the research from Katzengold and Geffen, we can identify how it compares to those traditional products that may be currently in practice. Things like medical support foam, or even historic products like donuts, which hopefully are no longer in use in your practice. But we can see through some of the biomechanical evidence or biomechanical engineering data, especially in this finite element analysis, where there are different capabilities of the products we utilize. And so from a Z-Flow perspective, we can utilize these products to not only have a better redistribution of that pressure and shear, but more importantly, with that zero memory, allow us to mold the product away from devices or even offload various structures of the head, such as the ear, for example. The next checklist item from the authors is to use a structured skin assessment and document findings. And I think one of the key attributes of their recommendations comes in that third bullet, that palpation of dark skin tones. And unfortunately, we have too long have been teaching pressure injury assessment and skin assessment on a Caucasian model. And the problem is, we know from studies by Fogarty and colleagues, for example, that African Americans have a much higher risk of pressure injury formation compared to Caucasians. And their data actually also shows that there's a greater severity. And so if we're only teaching our staff to look for color change, patients with dark skin tones are going to be at a detriment, because by the time we see skin change, it's probably going to be too late. When we also start looking at other very specific items like moisture management and incontinence management, we have to also consider practice changes, such as only using single layers of these sheets in order to manage incontinence and not stacking multiple layers, which can increase the risk of pressure and shear from those folded linens being under the patient. Medical device prevention and awareness remains low and inconsistent in a lot of facilities. And what I would say is, when we're following those NPIAP guidelines, and especially those downloadable resources available from their website, which suggest that we should cushion or pad the skin in between medical devices, we understand which devices are appropriate for these types of interventions. And more importantly, when we're going to introduce products such as Mepilex Light, we actually have underlying evidence that demonstrates their efficacy. And that's actually been shown in multiple studies, but particularly in the Bosch study, where they added these soft silicone dressings, these Mepilex Light dressings, in addition to their pressure injury prevention program for medical devices, and could demonstrate an impact. I think one of the most important steps is that repositioning and mobility. And we all know frequent turning is necessary, but are we maintaining that patient in the appropriate turn angle? Are we truly offloading those dependent bony prominences? That's one question. The next is, how do we utilize the evidence for turning and repositioning schedules to our advantage? For example, we often recommend every 2-hour turns, but when we look at some of the evidence from DeFleur and Behringer, for example, we know that if they're on a sufficient surface, there's not much difference between that every 2, 3, and 4-hour turning. So from our standpoint, we need to make sure our staff are turning frequently, but when we have maybe those hemodynamically unstable patients, or those patients who might have considerable issues with turning based upon their clinical condition or trauma, for example, we can utilize this evidence to our advantage, providing that evidence-based support surface, that pressure redistribution surface, in order to modify our clinical practice. From our standpoint, what we really try to do to support the clinician is provide evidence-based custom solutions. And so when we look at our tortoise turning and positioning system, we have to remember that that tortoise system is not just a turning system. And there was a recommendation that you look for that, that air-filled surface that can actually provide offloading to the dependent bony prominences, whether in supine or prone position. And so we understand that this addition of the tortoise positioning system can not only augment the immersion into the specialty bed as reported by Evan Call's work, but when we have the need to prone patients, as we've seen a dramatic rise recently to manage ARDS, we have a system that can not only get the patient into position, but can also offload pressure and shear. However, we understand that especially in these recent times, we've seen facilities that have gone from the need to prone, patients in a 20-bed ICU to all of a sudden having a 100-bed ICU, if you will, where they need to really respond to the challenge of this pandemic. And what we try to do is work with our evidence and work with our customers to understand what's feasible and would work well. And so we've actually been able to offer not only tortoise prone, but also utilizing those Z-flow positioners to create custom and maybe more easy to implement practices such as you see in the patient in the middle of the screen. And also for those facilities who maybe already have an established turning process for proning or already have the appropriate resources to position the patient, can we add dressings to the patient's body in order to help mitigate the risk of pressure and shear? And so that's a way that we've been able to respond as a company in these times to work with our customers to implement evidence-based practice and evidence-based dressings together within a specific facility protocol. I think the one thing we don't do a very good job of is we're constantly looking out for the protection of the patient, but we also forget about the prevention of injuries to the provider. And that's where, again, we try to look for solutions that capture all of this risk, and tortoise prone has been demonstrated to help with that safe patient handling benefit as well. The next checklist item from Dr. Padula and Black was to limit pressure, friction, and shear reduction. And we've seen a lot of this through the evidence that looks at subscale interventions as far as what subscale interventions are more prognostic for injury. And that pressure and friction and shear reduction is huge in this case. And so we have to consider alleviating pressure through effective use of these repositioning devices. But when we talk about evidence, their recommendation is for the application of a soft silicone 5-layer dressing, especially on the sacrum and heel. And when certain things like heel offloading devices, in the case of heel prevention, are not feasible to be utilized for a variety of clinical or behavioral reasons, utilizing the evidence that suggests the use of heel dressings in this case may help to limit that pressure, friction, and shear impact. And so I think this is where we pair our multiple randomized controlled trials that show the efficacy of these dressings for sacrum and heel prevention, not only from an aspect of clinical outcomes in these RCTs, but also through modeling studies that show the impact of these dressing at the muscle-bone interface. Again, going back to where is the patient at greatest risk and how do we mitigate that impact? So being able to utilize MEPLX border on heel and sacrum or MEPLX border flex in our prone patients, that's where we focus our evidence to match some of these clinical recommendations. Overall, I think when you're working for a pressure injury prevention program across an organization, it takes a lot of hands on deck and it takes a lot of resources, some of which a hospital doesn't have. And that's why it's important to evaluate your vendors for their ability to provide services that help implement this prevention across the board. And what we like to do at Munluca is partner with our facilities, partner with our providers, and provide that full scope of prevention from offloading to specific anatomical location prevention, positioning, as well as not only turning, but also positioning of the occiput or even with medical devices, and also look out for caregiver prevention. But at the same time, again, one of the key elements going back to checklist point number 1 from the authors was how do we educate and onboard our staff? And one of the things that we provide is the Connect to Know platform, where your facility can utilize both continuing education lectures where you can improve your education and get CEs for this in multiple aspects of pressure injury prevention, but also there's available webinars from experts in pressure injury prevention to help you with implementation of evidence-based dressings into evidence-based practice. The one thing that we're constantly struggling with, I think, in facilities all around the world is we do a very good job of how do we prevent pressure injuries, or what do we need to put into place from a bundle perspective or a protocol perspective for prevention. But when a pressure injury does occur, what do you do next? And I think it's important that when a pressure injury occurs, your prevention role is not over. We've now switched into an area where we have to mitigate recurrent injury. We have to continue to provide good wound bed preparation. And then we have to manage the specifics of the wound, like exudate management, or even as shown by some recent studies in the Journal of Wound Bed and Wound Repair and Regeneration, the impact of dressings such as Hydrofiber AG can have on reducing bioburden and biofilm. But ultimately, when we select products, it's not just about their clinical outcomes, but it's also their performance. And that's why we're really proud to introduce the Mepilex Border Flex dressing, which adds not only that support of wound healing, but also the performance characteristics where you won't be wasting resources through inappropriate performance. And so I'd finally like to say that when you're evaluating products, it's very important that you understand what products have evidence to achieve that clinical outcome. And when you don't have evidence, how do you do an appropriate clinical evaluation? From our standpoint, when we're introducing the use of our products within best practice guidelines, we like to go back to our focus on evidence for our products so that you, the provider, know that when you utilize our products, you're not only going to get a dressing or a product that is going to help you in your pressure ulcer prevention journey, but in addition, it's going to perform the way you expect it. And I think our comparative evidence out in the literature, as well as the overall quantity of research for our products compared to other options, really speaks for itself. So in summary, I'd like to say that reducing facility-acquired pressure injuries is a complex undertaking. We have to start with that hospital level. How do we engage staff, as Dr. Padula and Dr. Black indicated? How do we use data and staff education to make sure that we're correctly identifying pressure injuries and identifying where we need to focus our resources? I believe that the SPIP protocol really provides an evidence-based guide to 6 essential components that should be adopted in any program and can be used in tandem with the new NPIAP clinical practice guidelines. And finally, I'd like to say, please encourage you to reach out to your Mölnlycke representative, because we really invest a lot of time in our resources and our support of our facilities and clinicians so that you have solutions for prevention and management of pressure injuries, and we can provide you with the latest up-to-date evidence-based resources in order to help you make the appropriate decision. Thanks so much for having me today.
Hello, continuing with the Smith & Nephew portion of the presentation, we're going to be discussing pressure injury prevention. My name is Angela Rose. I'm a family nurse practitioner. I've worked as an RN for 8 years and a nurse practitioner for the last 3 years, working exclusively in wound care in an inpatient and outpatient clinic setting. I am a paid consultant of Smith & Nephew. I'm also on the LEAP Speaker Bureau for Smith & Nephew. So we're going to be discussing pressure injury prevention in the hospital. National hospital-acquired pressure injury rates are increasing. It's not only a prevalent problem, but it's also costly. Although other hospital-acquired issues such as ventilator-associated pneumonias, catheter-associated urinary tract infections, those numbers overall are going down for a total of 13%. Hospital-acquired pressure injury rates have increased 6%. The impact of pressure injuries in American hospitals is not only a prevalent problem, it's a costly problem. They've analyzed over 9 million patient records and come up with an average for each pressure injury is over $21,000. It adds an average of 9.5 days to the length of admission, and it increases their chance to be readmitted. Every 5 years, the International Clinical Practice Guidelines are updated. At the last update in 2014, it was very carefully worded to consider applying a polyurethane foam dressing to bony prominences for prophylaxis. As of the 2019 update, it's more strongly worded, and it says to use a soft silicone multi-layered foam dressing to protect the skin for individuals at risk for pressure injury. Smith & Nephew has the Alleven Life Foam Dressing. It's got a unique 5-layered foam. It can be left on for 7 days in most areas, with the exception of the sacrum, which is a 5-day wear time. It's very gentle on fragile skin. I practiced using them myself when we first introduced it at our facility. I was able to lift and replace the outer silicone, and it never caused any pain, didn't pull the hair, and it still continued to be sticky. Compared to standard care alone, the Allevian Life dressings can decrease the incidence of sacral pressure injuries by up to 71% and decrease the cost of care per patient by up to 69%. In our facility, and I'm sure everywhere right now with the pandemic that we're in, we are experiencing unprecedented amounts of having to prone patients. And I've been in talks with our ICU about ways we can prevent pressure injuries. We are using the leave-ins here on areas that you don't anticipate having to protect: the forehead, the chin, genitalia, the knees, the toes. So each of these little orange circles represents a bony prominence that is at risk for skin breakdown due to pressure. Also included in the updated clinical practice guidelines this year was discussing the importance of repositioning patients on an individualized turning schedule. At our facility, we've always had a Q2 turn protocol, as most of us had for over 200 years, but the guidelines want us to be more individualized, fit it to the patient, their needs, make sure that we are optimally offloading their bony prominences, and then also it wants us to implement the use of reminder strategies such as wearable sternal sensors, musical cues, turn clocks and prompts. The issues with musical cues or turn clocks and prompts, we can hear those, ignore them, we get used to them. We need something that's going to be more of a reminder that's easy to follow without tuning it out. So we'd like to introduce the LEAF patient monitoring system. It's a wearable sternal sensor that goes on like a tele lead or an EKG sticker. It's a color-coded, silent monitoring system. And we're going to watch a video on that.
At the core of the LEAF system is the wireless wearable patient sensor. The single patient use device weighs less than an ounce, is waterproof, and has a battery life of up to 16 days. When placed anywhere on the patient's upper anterior torso, the sensor automatically begins monitoring the patient's position and activity, regardless of whether they are lying in bed, sitting upright in bed, sitting upright in a chair, or moving about. The sensor communicates wirelessly through a proprietary mesh network to centralized monitors that display the patient's current position and visually alert staff when repositioning is needed. This display helps staff identify and prioritize who needs to be turned and when.
As you saw in the video, LEAF optimizes patient repositioning using the IPI, or the Integrated Positioning Index. So it delivers the right dose to the right patient at the right time. They have a turn frequency that's set per the facility protocol, but it also takes into account patient movements. We make sure that we turn them the right amount, the right degree, and that we give enough time for the tissue to adequately recover. Using LEAF, there was an almost double increase in adherence to turn protocol. It went from 48%, which is the average US adherence without LEAF, to 92% in a large study. The reduction in pressure injuries using LEAF resulted in a 73% decrease. In a large randomized controlled trial in 2 critical care units in California, they analyzed over 1,200 patients for over 100,000 hours and saw this large reduction. Smith & Nephew offers a comprehensive pressure injury prevention solution to address a complex problem. We have the prophylactic Allevian Life foam dressings, repositioning assistance with the LEAF patient monitoring system, and skincare with the Secura skincare line. Thank you so much for attending this presentation. I hope you enjoy the rest of the conference. Have a great day.
Hello and welcome to this context supported section of the workshop. My name is Phil Bowler. I'm the VP for Science and Technology, R&D at Convatec, with many years of experience in wound infection, wound biofilm, infection prevention, and the development of innovative wound management technologies. This workshop is supported in part by Convatec and to confirm I am an employee of Convatec. So in this short presentation, I'm going to be talking to you about the use of Hydrofiber technology in wound management. And by the end of this session, you will have learned about the 3 unique properties of Hydrofiber technology, the benefits that these properties provide in pressure injury prevention and management, and the application of Hydrofiber technology in a range of dressings to meet a variety of clinical needs. So let's start by talking about the clinical consequences of inadequate exudate management. Of course, chronic wounds produce exudate, and that exudate can be highly toxic, contains many enzymes that can be very degrading to the wound itself and also to the surrounding skin. So management of that exudate is really important. And what you can see on the left-hand photograph in this slide here is a pretty nasty wound that has been poorly managed with a gauze dressing. The gauze dressing has not been able to manage the exudate effectively. You can see that that fluid has been taken up into the dressing, but it's tracked laterally. It's wicked across the dressing, meaning that it moves across the wound surface onto the surrounding skin, leading to maceration of that skin and further damage. So this is an example of a very poorly managed wound. And similarly, we see on the right hand side here, we see another wound where the fluid has been allowed to leak out of the wound onto the base of that wound to again cause excoriation and maceration of that peri-ulcer tissue. So with inadequate exudate management, the exudate can be very corrosive and destructive, not only to the wound, but to the surrounding skin. So Hydrofiber technology was developed to manage wound exudate more effectively than dressings such as gauzes and also alginates. So in this series of slides that you can see in this particular slide, top left here, we see what Hydrofiber is about. And essentially, Hydrofiber is based on the same material as gauzes. It's based on cellulose. But what we do with Hydrofiber is to chemically modify it so that wound exudate or fluid in general is taken up into the core of the fiber. And what you can see top left here is a cartoon of the fibers actually absorbing fluid and swelling. So as these fibers absorb fluid, they increase in volume, they compress against each other, and they form a very cohesive gel that traps that fluid, and it traps components of the wound fluid like bacteria, like caustic enzymes within that gelled matrix. And beneath you can see a scanning electron microscope of E. coli cells that have been trapped by the gelled matrix that has formed when the Hydrofiber has hydrated. If we look at top middle now, we can see 2 dressings. Comparing 2 dressings here, we've got an alginate versus a Hydrofiber. The top dressing is alginate dressing. So strips of 2 dressings, alginate and Hydrofiber, have been cut and placed into Petri dishes containing a blue dyed solution. And you can see with the alginate how the fluid has been absorbed into the alginate dressing, but it's tracked laterally over the rim of the Petri dish and beyond the edge of the dish, whereas beneath that you can see Hydrofiber technology, how it's formed this really thick and cohesive gel, and it's prevented that lateral wicking. So what does that mean clinically? Well, beneath it you can see an Aquacel dressing that has been used here in a wound, and you can see that the fluid from the wound has been absorbed vertically into the dressing, but the dressing has prevented that lateral wicking to protect the surrounding skin. And what we can also see with this particular dressing is that once it's gelled, it conforms very, very effectively to the topography of the wound. So it fills any voids where bacteria may collect and become a nidus for infection. So the dressing, once it's hydrated, is very effective at removing all those voids where bacteria may become a problem. At the bottom right here, you can see a very simple test to look at the absorbent characteristics of Hydrofiber technology. We have 3 dyed solutions, the green, the yellow and the orange, and then a beaker of water at the end. So what we do is to take that strip of hydrofiber and we place it about 1 centimeter into the green dye. We take it out and then place it about 2 centimeters deep into the yellow dye, out again, and then about 3 centimeters into the orange or red dye, and then finally 4 centimeters into the water. And you can see that dressing, how each of those dyes have been locked in that portion of the dressing, which very effectively shows how hydrofiber technology holds onto that fluid and prevents it moving within that dressing. So as the dressing has been dipped into water in this final dip, none of that dye has been released. It's all been held into the dressing, which is what it will do clinically. Clinically, in a wound environment, it will hold on to that exudate, and it will hold on to the components of the wound exudate, like caustic enzymes and bacteria. So let's take a look at this visually in the next two videos.
Wounds represent a breakdown in the protective function of the skin, thus providing a portal of entry for bacteria. Chronic exudate is a corrosive biological fluid due to the presence of harmful components such as bacteria and enzymes. Dressings containing hydrofiber technology have unique gelling properties which are beneficial to wound management, locking in exudate and its harmful components, contouring to the wound surface, and responding to the wound environment by forming a cohesive gel. When dressings containing hydrofiber technology come in contact with exudate, the individual fibers swell to form a cohesive gel that locks in exudate and controls the flow of fluid. Harmful components such as bacteria and enzymes that are contained in exudate become locked inside the dressing. Neutrophils are also locked away, preventing the release of their damaging enzymes. The ability to lock in these harmful components helps protect peri-wound skin, reducing the risk of maceration. Hydrofiber technology forms a soft, cohesive gel that contours over the surface of the wound, providing a warm, moist environment that is conducive to healing. This means that all the spaces between the wound and the dressing are filled, removing areas in which bacteria may proliferate and protecting nerve endings from drying out. The gel's dressing is also easy to remove and reduces pain on removal as it does not adhere to the wound bed. Dressings containing hydrofiber technology respond to the wound environment by forming a cohesive gel that maintains moisture balance throughout the wear time of the dressing. If the amount of bacteria in the wound rises, there's an increased risk of infection. The addition of silver ions into dressings containing hydrofiber technology has been shown to provide broad-spectrum antimicrobial activity. Bacteria become locked inside the dressing and are killed. The activity of enzymes, such as matrix metalloproteinases, is reduced in the presence of silver ions, as demonstrated through in vitro testing. Hydrofiber technology provides a reservoir of silver ions inside the dressing. Silver ions are made available on demand, responding to any rising bacterial enzyme activity with increased silver ion availability, as demonstrated in vitro testing. Therefore, antimicrobial activity can be sustained for the wear time of the dressing.
So moving on to current clinical practice guidelines for the management of pressure injuries. The National Pressure Injury Advisory Panel advocates the use of foam dressings in stage 2 and greater pressure injuries with moderate to heavy exudate, and this was reported by the panel back in 2019. The WOCN core curriculum on wound management from 2016 quotes that foam dressings are appropriate for wounds with low to moderate exudate, but also for heavily exudative wounds. But they also advise that the clinician must consider the volume of wound exudate when selecting a foam dressing with the appropriate absorptive capacity. So let's look at some of the practical applications of Hydrofiber technology.
Apply the primary dressing Aquacel AG Advantage here to the wound, overlapping at least 1 centimeter onto the surrounding skin. Select the appropriate size and shape foam dressing, holding the dressing over the wound and lining up the center of the dressing with the center of the wound. Peel back one side of the clear liner and remove, attaching the dressing adhesive border to the patient's skin to secure. Remove the other half of the clear liner and secure the other side of the dressing. Smooth the adhesive border down with your hands to secure. Fold the dressing over the bottom of the heel and, accommodating for the curvature of the heel, attach and smooth down the adhesive border along the edges to complete the dressing application. Smooth down all areas of the adhesive border over the patient's skin. For this full-thickness sacral wound, Aquacel foam sacral dressing is used as a secondary dressing over the primary dressing of Aquacel AG Advantage after cleansing the wound and surrounding skin. Gently place an Aquacel AG Advantage dressing into the wound cavity. The sheet may be folded or cut to fit as needed. Cover the wound with an appropriate size Aquacel foam sacral dressing. Remove the central release liner on the back of the dressing first, then, holding the dressing at its edges, fold it in half with the non-adhesive sides touching. Place the inside fold into the natal cleft. Keep the center pad in contact with the sacral area. Remove the clear dressing liner on the side closest to you and smooth down the adhesive borders of the dressing into place. Remove the remaining clear liner, pulling it away, and attach the remaining adhesive border of the dressing onto the patient's skin. Gently smooth down the adhesive border, removing any wrinkles in the dressing to complete the application. The Aquacel foam dressing may be used as a primary or secondary dressing and should be changed when clinically indicated or within the maximum recommended wear time of 7 days. The Hydrofiber primary and secondary dressings used together provide effective transfer of exudate from the primary Aquacel dressing into the secondary Aquacel foam dressing.
Moving on to looking at the benefits of Hydrofiber technology in skin protection. And what you can see in this slide is one of the Aquacel foam dressings. This is Aquacel Foam Pro. And you can see that there are 5 layers to this dressing. Layer 5 that you can see is the wound contact layer. This is the gentle silicone adhesive that provides secure and skin-friendly adhesion. It's easy to apply and remove. The adhesive doesn't stick to itself or gloves, and it allows repositioning on initial application. Behind the adhesive silicone layer, we have the Hydrofiber layer, which I've already referred to. Its ability to absorb exudate, form this cohesive gel, which locks components of wound fluid within that gel. Layer 3 is the binding layer that essentially binds together the Hydrofiber layer with the soft foam layer that provides additional soft cushioning for the dressing. And the outer layer of the dressing is the smooth and breathable waterproof film, which minimizes shear and friction, for example, between bed linen and the dressing itself. So referring back to the MP-IAP clinical practice guideline, reference is made to the use of a soft silicone multi-layered foam dressing to protect the skin of individuals at risk of pressure injuries, with consideration being given to the many factors which help in the selection of the optimal prophylactic dressing, such as the ability to manage the microclimate, which we know Hydrofiber technology achieves very effectively, and also consideration to prophylactic dressings with features that facilitate regular, for example, daily skin assessment, which again we know is where a skin-friendly adhesive is clinically very beneficial. So I mentioned at the outset that Hydrofiber technology is used in a range of dressings to meet a variety of clinical needs. And this slide just gives an indication of some of the dressings containing Hydrofiber technology. From, on the left-hand side, the original Aquacel dressing. That was followed by Aquacel Extra, which was developed to provide added absorbency and also strength to the dressing to enable removal of the dressing in one piece. The ribbon dressing with strengthening fibre for sinus and tracking wounds, again to be able to be removed in one piece. And then on the right hand side we see Aquacel AG Advantage. This is one of the most recent additions to the Aquacel family. As the name implies, this is a silver containing dressing, but it also contains another technology which helps to break down the complex microbial communities that are found in chronic and non-healing wounds. And this allows the silver in the dressing to work much more effectively. And what you can see at the bottom here is Aquacel Foam and Aquacel Foam Pro dressings, which are used in the prevention and management of pressure injuries. So this is the final slide from me, so thanks very much for your attention. Thank you.
Thank you for your participation. This concludes the industry-led workshop portion of this pre-conference. Our panelists look forward to answering your questions.